Let's go over the warm-up review. First question, what are the branches of the common hepatic artery? So there's the gastroduodenal artery, which gives rise to the right gastroomental artery, which is also called the right gastroepiploic artery. And then the other branch of the gastroduodenal artery is the anterior superior pancreaticoduodenal artery. Then the second branch off the common hepatic is the right gastric artery. And the third branch is the hepatic artery proper, which gives rise to the left hepatic artery and the right hepatic artery. And the last one, which cell type secretes the histamine that stimulates the histamine receptor on parietal cells of the stomach, thereby increasing gastric acid production? This is the enterochromaffin-like cells, or the ECL cells. Now let's move on to the lecture.
Hi, this video is the first of the Medicine in Society portion of the course, which is kind of a grab bag of several very important high-yield topics, including biostatistics, healthcare economics, and medical ethics. Now, in addition to being an infectious disease physician, I also have a Master of Public Health degree. So I'm going to kick off Medicine in Society by discussing some evidence-based medicine topics related to research study designs. The material in this video and the next is incredibly high yield. Students are often upset that they didn't spend more time studying this stuff because it's so high yield. So you really want to pay attention to this video. I think it's going to pay off for you. So let's dive right in and talk about some different ways that you could design a research study. We'll start with case control studies. A case control study compares a group of people with disease to a group without disease to look for potential risk factors or exposures that could account for the bad outcome. So this is the kind of study that the CDC or other public health entity might undertake if there's a disease outbreak. What you do is you take a group of people that all have the disease and put them into one group, and these are called the cases. And then you take a group of people who don't have the disease but are otherwise similar, and these are the controls. Then you look back over all of their recent food intake, environmental exposures, travel histories, etc., to see how these two groups, the cases and the controls, are different. And hopefully this leads to some exposure or risk factor that's linked to the bad outcome. So what I just described is both retrospective and observational. Like I said, as the investigator, I would take a history of exposures for the two groups. So I would ask all of the study participants to look back over some period of time and tell me what their exposures were. That backward-looking element to the study makes it a retrospective study. Besides being retrospective, case control studies are purely observational. There's no intervention here. There's no experimental arm. I was just observing what the cases and controls did in their everyday life. I, as the investigator, didn't intervene in any way. I merely observed what took place. So case control studies are retrospective and observational. It's important to remember that case control studies are used to identify risk factors for diseases, but this does not always mean that the identified risk factors are causal. All we can say is that there's some association between the risk factor and the disease. The outcome of a case control study yields an odds ratio. An odds ratio takes the odds that someone with the disease had the exposure in question and compares it to the odds that someone without the disease or the control also had that exposure in question. For example, you could measure the odds ratio for smoking and lung cancer. Smoking would be the exposure and lung cancer would be the disease. Then you would look at the odds that someone with lung cancer having smoked and divide it by the odds that someone without lung cancer has smoked. And the odds ratio can also be interpreted as the odds of having the disease from someone among the exposed divided by the odds of having the disease from among the unexposed. This is just another way of looking at the odds ratio. We'll talk more about calculating odds ratios later on. Next, let's look at cohort studies. Now, a cohort is a group of people that have something in common, like a common exposure. So you can have a group of people that have all had a certain exposure, say asbestos exposure, and compare them to a cohort of people who had not had asbestos exposure. Then you follow both cohorts to see what the outcomes are among the exposed versus the non-exposed. This is still purely an observational study. We still aren't doing any sort of intervention here. But a cohort study could be either retrospective or prospective. An investigator may form a cohort based on a recent exposure and follow the participants into the future to see what the outcomes are. Alternatively, the investigator may look into the past, form a cohort out of people who all had a certain exposure at some point in time, and then follow them over a set period of time to see if the outcome of interest ever developed. In this case, both the exposure and the outcome all happened in the past. So to summarize, in a case control study, you take a group of people with a bad outcome and then compare them to a group without the bad outcome and look back at all of their exposures to determine risk factors. In a cohort study, you take a group of people with an exposure or risk factor and then see what happens to them over time. So how do we analyze cohort studies? Cohort studies yield a relative risk or a risk ratio. So a case control study gives you an odds ratio, and a cohort study gives you a risk ratio or relative risk. To calculate relative risk, you divide the risk or rate of the disease in the exposed group by the risk or rate of the disease in the unexposed group. It tells you how many times greater the risk for a bad outcome is among the exposed compared to the unexposed. Now, this may sound a lot like odds ratio, and it is. The odds ratio, though, is considered an approximation of the relative risk. In a case control study, the total population can't be known. So a true relative risk can't be calculated, but an odds ratio can. And that odds ratio stands as an approximation of a relative risk. But a cohort study does have the population variable, so you can calculate a true relative risk. Now, let's move on to cross-sectional studies. A cross-sectional study looks at a population at one point in time. Say you want to know how many people in the U.S. have COPD at one point in time, say January 1st, 2016. This study will tell you how many people in the U.S. had a diagnosis of COPD as of January 1st, 2016. You can also ask about risk factors. This will tell you how many people were smokers or were exposed to secondhand smoke on that day. This study will then give you a snapshot picture of the population and COPD at one point in time. So from this study, you can estimate how many people in the U.S. have COPD and how many of them have known risk factors. This is a quick and easy way to figure out how many people in a population have a disease at any point in time, which is known as prevalence. However, there's a lot of things that a cross-sectional study can't tell you. It can't tell you how many people are developing the disease every year, which is known as the incidence. And it can't tell you if the disease is becoming more or less prevalent. It can't tell you how the exposures and the disease outcomes are related over time. So it can't demonstrate causality. So a cross-sectional study is observational. Since we're not manipulating any of the study factors, we're just merely observing what people are doing at a given point in time. And we would not say that it's retrospective or prospective because it's only looking at one point in time. Another type of purely observational study is the twin concordance study. A twin concordance study compares concordance rates of diseases or traits in identical twins and in fraternal twins to measure heritability of those diseases or traits. A similar study is the adoption study. By studying twins that were raised in separate homes, these studies usually seek to determine the impact of genetics versus environmental factors, the old kind of nature versus nurture question. Now let's move on to clinical trials. What's a clinical trial? A clinical trial is an experimental study where the investigator is intervening to draw a conclusion. So we've moved beyond that pure observation to intervention. The investigator is giving one group of participants the experimental therapy and another group of participants either a comparison treatment or a placebo. Now, with the clinical trials, you're using human subjects, and that's a huge deal. Clinical trials are expensive and they can be dangerous. So how do you make them high quality and reliable? One way is to make them controlled, randomized, and double-blinded. What does all that mean? Well, controlled means that there is not only an experimental group who receives the experimental treatment, but there's also a control group that gets either a placebo or a comparator drug that's well known. And in this way, the experimental group can be measured against another group that's receiving a known treatment. Now, randomized refers to the participants being randomly assigned to the experimental group or the control group, and this is to limit bias. Now, double-blinded means that the study design does not allow either the participant or the investigator to know whether that participant is receiving experimental treatment or the control drug or placebo. So that's a little bit about the basic design of clinical trials. Now let's talk about the phases of trials that we use to develop new drugs. I'm going to sum up each of these phases for you in a simple question. The question for phase 1 trials is the drug safe? In phase 1 of a clinical trial, you're giving the drug to healthy volunteers in order to determine if the drug is safe and what the pharmacokinetics of the drug are. So in phase 1, you want to know if the drug is safe in healthy volunteers and how a healthy body handles that drug. So phase 1 determines if the drug is safe by looking for toxicities. Who participates in these phase 1 trials? You probably know. College students. There are a lot of healthy college student volunteers participating in phase 1 trials. Young, healthy individuals. Actually, a lot of times will use medical students, so maybe you've even participated in this phase of a trial before. For phase 2 trials, the question we're asking is, does the drug work? So you look at patients with the disease. This is the stage where they give the drug to a few patients with the disease to measure efficacy of treatment, appropriate dosing, and again, adverse effects. So in this phase, you're giving the drug to the target population to see if it works in the population that it's intended for. Then the question for phase 3 trial is, does the drug work better? Is it better than a placebo or better than the established treatment? So phase 3 trials are the trials that you commonly see in medical journals where you're comparing an experimental drug to the drug that already exists on the market. The question is, does it work better? Does it work better than what's already out there and is currently recommended? Then phase 4 is post-marketing surveillance. So a drug company has to provide data from their phase 1, 2, and 3 clinical trials in order to get an FDA approval. Then once the drug is approved and it's on the market, they still have to monitor for additional problems. This is when some of those less common adverse effects come to light, once that drug is broadly marketed and widely used. So this phase is good for identifying rare adverse effects or long-term effects of therapy. And you can imagine that it takes a very long time to get through all of these phases of trials, and it's very expensive. Okay, let's briefly talk about one other study design that's important to understand, and that's the meta-analysis. A meta-analysis combines data from many studies in order to provide better insight than any one of those studies would have been able to provide individually. By combining several studies together, the investigators can increase the statistical power and thereby reach statistically significant conclusions that may have been hidden when the studies were evaluated individually. So as an example, say there are a lot of studies looking at statins and the risk reduction for myocardial infarctions. So you take each of these statin studies and combine them all together and see if, as a class, those statin drugs reduce overall risk of an MI. So you're pooling studies together. And there are a lot of pitfalls inherent to meta-analyses. The investigators themselves are responsible for outlining the inclusion criteria for the related studies and are also responsible for judging the studies based on those criteria. And this is where this selection bias creeps in. We'll talk about bias in another video. Also, the quality of the entire meta-analysis depends on the quality of each of those individual studies. So all this to say that meta-analyses have some major strengths. There's also some major potential weaknesses there. All right, that is it for now. Let's go through your end of session quiz. Go ahead and pause the video, answer those questions, and then we'll go through the answers together. All right, let's get started. A physician is looking for risk factors for pancreatitis, and he interviews 100 hospitalized patients with pancreatitis and 100 hospital patients without pancreatitis. What type of study is this? This is a case control study. He's looking for risk factors, and he's starting with a diseased population and then looking for exposures retrospectively. Next, a group of smokers and a group of non-smokers are followed over 20 years, and every 2 years it's determined who develops cancer and who does not. What type of study is this? In this study, you're starting with an exposed population and then looking for a specific outcome. So this is a cohort study. Next, can a cross-sectional study help determine incidence or prevalence of a disease? Remember, a cross-sectional study looks at a population at one point in time. It can tell you about the number of people with disease or risk factors at one point in time, and that's prevalence. But it can't tell you how many people are developing a disease, and it can't determine causality. All right, that's it for our lecture on research study designs. I'll see you next time.
Let's go over the answers to the warm-up. First question, what clinical features suggest congenital pyloric stenosis? Well, it's usually seen in patients 2 to 6 weeks of age, and it's more common in male infants than in females. The classic presentation is firstborn males. Patients present with non-bilious projectile vomiting, and because of the vomiting, they often have dehydration and possibly some metabolic alkalosis, which is going to be a hypokalemic, hypochloremic metabolic alkalosis if they've been vomiting for at least 5 days. On physical exam, you may feel a palpable olive-like bulge in the upper abdomen, and you may see slow peristaltic waves across the abdomen just before the baby vomits, moving from left to right across the abdomen. Next, what are the features of Plummer-Vinson syndrome? Plummer-Vinson syndrome is a triad of dysphagia from esophageal webs, glossitis, and iron deficiency. And the last one, what is Dressler syndrome? Dressler syndrome is pericarditis that occurs usually 2 to 4 weeks or more after an MI. The patient can present with chest pain, fever, and an increased sed rate. All right, let's move on to the lecture.
Hi. In this lecture, we will move on to the evaluation of diagnostic tests. This is a 5-star topic. This is huge. You're going to have a few questions on sensitivity, specificity, positive and negative predictive value, what these terms mean, and how to calculate them. So you need to be very diagnostic test savvy. You should study this stuff and know it very, very well, and I promise that it's not difficult and it could really pay off for you. The first thing you need to be able to do is construct a 2x2 table that we use to evaluate diagnostic tests. If you can learn how to draw this table and fill in the numbers, that's 90% of the battle. Basically, memorize this table. Look along the y-axis here and see that it's labeled test, which can either be positive or negative. Now look at the x-axis and see that is labeled disease. The patient can either be positive for disease, that is the disease is present, or negative for that disease, the disease is absent. Some students use the mnemonic, disease always comes out on top. A little depressing, but it can help you remember that disease is written along that x-axis. Now, by knowing whether the test was positive or negative and whether the disease was present or absent, we can determine how good that test is. Specifically, how sensitive, how specific, how accurate a positive or negative value for that test actually is. So true positives are people that have a positive test who actually have the disease. That's exactly what you would want. People that test positive and don't have the disease are considered a false positive. But people that have the disease and are testing negative, they're a false negative, and you don't want that either. People that don't have the disease that are testing negative would be a true negative, and again, that's a desirable situation. Okay, let's first talk about sensitivity. How do we determine the sensitivity of the test? Well, the sensitivity is a calculation of all the true positives divided by everyone who actually has the disease. That is, the true positives plus the false negatives. So true positives are in the numerator, and the true positives plus false negatives are in the denominator. This is the proportion of people with the disease who get a positive test result. It's really very simple. So you have a group of 10 people that you know have HIV, and so you do an ELISA test, and the likelihood that the ELISA test will be positive in all 10 people is your sensitivity. If there's 100% sensitivity, then everybody in this group tests positive, and you will not have any false negatives. So sensitivity would be 1. Another way to calculate sensitivity is 1 minus the false negative rate. So in this ELISA example, with no false negatives, you have 1 minus 0 equals 1. Now, when I learned this, I actually learned sensitivity equals PID. Now, PID can mean pelvic inflammatory disease, so it's a very common acronym and used for a disease that causes a lot of pelvic sensitivity. But here it means positive in disease. So sensitivity equals the proportion of disease to people who have a positive test. That is, the proportion that have a positive test in the presence of disease, PID. Okay, now for specificity. Specificity is the proportion of all people without the disease who have a negative test result. Or another way to say that would be all those without the disease who correctly test negative. The true negatives divided by the total without the disease. So this would be the true negatives divided by your true negatives plus false positives. So let's say that you had 10 people without disease A that you tested using the new screening test. Of the 10 tested, 2 tested positive and 8 tested negative. To calculate the specificity of the test, you would put the number of true negatives in the numerator and the total true negatives plus false positives in the denominator. In this case, it would be 8 divided by 10, which equals 0.8 or 80%. Another way to calculate this specificity is 1 minus the false positive rate. The false positive rate is the number of false positives, in this case 2, over the total false positives plus true negatives, in this case 10. So 2 over 10 would be 0.2. So the specificity would be 1 minus 0.2, which is 0.8 or 80%. So again, when I was learning about this in medical school, I learned specificity equals NIH. So the NIH can mean the National Institutes of Health, so again, a common acronym. But here for specificity, it means negative in health. Specificity is the proportion of people who have a negative test result in the presence of health. NIH equals negative in health. Different approaches work for different people. Whatever works for you to understand this, just do it that way. If nothing else, just memorize the equations. You can use A, B, C, and D's to fill in the table. If you know the equations, know your diagram, and know where your true positives, false positives, true negatives, and false negatives fall into that diagram, then that's probably 90% of the battle here. Whichever way you choose to remember this stuff is fine. In fact, on the day of your test, I would recommend that you take a couple of minutes at the very beginning of your first block of questions and draw a little 2x2 table and write down all these equations. This is a great marker board topic. Let's talk about a clinical use for sensitivity and specificity. If we were screening for a life-threatening illness like cancer, would you want to use a test that offers high sensitivity or high specificity? Well, obviously, in an ideal world, we would maximize both. But if you can't, then for screening tests, we want a higher sensitivity. A screening test needs a higher sensitivity in order to capture all of the true positives. But that needs to be balanced by a diagnostic test with high specificity so that the healthy individuals are not given false positive results. There's a trade-off between sensitivity and specificity, and it's very difficult to get both optimized in the same test. It would be most desirable to have a high sensitivity and high specificity for both the screening test and the diagnostic test. If you have to choose one over the other, though, you want high sensitivity for the screening test and high specificity for the diagnostic test. One last thing about sensitivity and specificity, look again at our 2x2 table. Sensitivity and specificity are both vertical calculations. Can you see that? That for sensitivity, you take the true positives and divide them by the true positives plus false negatives, which is the sum of that first column. And for the specificity, again, you do a vertical calculation. For specificity, though, you start at the bottom of the second column, put the true negatives in the numerator, and divide it by the total of true negatives and false positives, which is the sum of the second column. Okay, now look again at that table. What happens if we do those calculations horizontally? The horizontal calculations are the positive and negative predictive values. So let's talk about those now. Look at the first row of the table. Positive predictive value takes all of your true positives and divides them by everybody that tested positive. So what is that telling you? It's telling you the probability that a person who tests positive actually has the disease. The name kind of says it all. What is the predictive value of a positive test result? How well does a positive test result predict the presence of a disease? It's the proportion of all the positive test results that are true positives. So say a patient comes to your clinic and tests positive for mononucleosis, and then they ask you what the likelihood is that they actually have mononucleosis. What they're asking you is the positive predictive value of the particular test that you ran. Now, look at the second row. The negative predictive value is the true negatives divided by everyone that tested negative. So again, we're going horizontal on your diagram. True negatives divided by everybody that tested negative. What does that tell you? Again, it's telling you the probability that a person who tests negative is actually disease-free. Again, the name says it all, negative predictive value. So how well does a negative test result predict the absence of disease? It's the proportion of all the negative test results that are true negatives. So for positive and negative predictive values, you will be doing horizontal calculations in your 2x2 table. For positive predictive value, you would put the true positives in the numerator and put all of the positive test results in the denominator, the true positives plus the false positives. And likewise, for the negative predictive value, you would do a horizontal calculation with the negative test results. You would start at the bottom and put the true negatives in the numerator and then put all of the negative test results in the denominator. True negatives plus false negatives. So hopefully at this point this is all beginning to sink in. It really isn't difficult, and it can be very good to know this for test-taking purposes. All right, let's get some practice doing these calculations. Take a look in your study guide and let's go through this question together. It asks you to calculate sensitivity, specificity, and positive and negative predictive value using the table that we've provided. You don't actually have to work the long division. Just pause the video and take a moment to set up the ratios, and then we'll go over the answers. Sensitivity is true positives divided by everybody with the disease. So here the number is 800 divided by 800 plus 100, or 800 over 900. Specificity is the true negatives divided by everybody who does not have the disease. So this is 1,400 divided by the sum of 200 plus 1,400, or 1,400 over 1,600. Again, sensitivity and specificity are going vertically, and then positive predictive value and negative predictive value are going horizontally. Positive predictive value is the true positives divided by all the people who tested positive, so it's 800 divided by 800 plus 200, or it's 800 over 1,000. And then negative predictive value is your true negatives, which is 1,400, divided by everyone who tested negative, which is 1,500. So this is pretty basic. I hope you're seeing that, but it's definitely high yield for your test. One last concept to cover on positive and negative predictive values is that the predictive values change as disease prevalence changes. So sensitivity and specificity are static. They don't change, but positive and negative predictive value, they do change according to disease prevalence. Positive predictive value increases with increasing disease prevalence. So in a low prevalence setting, even tests with high sensitivity and specificity result in low positive predictive values. This is one reason that you have to be really careful with screening tests in low prevalence situations. It might help you to look at this 2x2 table while we talk about this subject. So let's talk about a population with a high prevalence of a certain disease. If you have a lot of people with a particular disease, which values in the 2x2 table are going to change? You're going to be increasing number of people with disease compared with those that do not have disease. So the numbers in the first column will increase. If you increase the numbers in that first column, then what you see is an increase in your true positives and your false negatives. You're basically going to increase that whole vertical column when you have increasing prevalence of the disease, because the first column represents all the people who really do have the disease. So if you're increasing the true positives and the false negatives, what is that going to do to your positive predictive value? Looking at the equation, if you increase your true positives, it's going to increase the numerator. By increasing the numerator, you're going to increase the positive predictive value of the test. So high true positives and high prevalence equals a higher positive predictive value. Look at the equation for negative predictive value. We said with high prevalence, you are increasing your false negatives, which are in the denominator of the negative predictive value equation. By increasing your denominator, you are actually reducing the negative predictive value. When the disease is very prevalent in a population, a test with a given sensitivity and specificity will have a higher positive predictive value and a lower negative predictive value. It might help to think of it this way. When it's flu season and the prevalence of influenza is very high and somebody comes in with a high fever and body aches and all those flu symptoms, do you put more or less value on a positive flu test? Well, if that test is positive, you're going to believe it, right? And the positive predictive value is very high. What about a negative test? Well, if a patient comes in with symptoms of flu and are looking really ill, but they have a negative flu test, you're probably not going to believe that negative test, right? The negative predictive value is lower because the prevalence is so high. The reverse is true as well. If the prevalence is very low, the disease positive column decreases in value and your false positives and true negatives will increase. What happens when you're increasing your false positives and true negatives? How is this going to affect the equations? Well, in the equation for a positive predictive value, the increase in false positives will increase the value of the denominator. So decreasing disease prevalence will decrease positive predictive value. In the same way, decreasing prevalence increases the negative predictive value. So let's think about a real-world example where this comes into play. Do we screen every woman over the age of 50 for ovarian cancer by checking a CA-125 to screen? No, because the prevalence of the disease is low. With such a low disease prevalence, the positive predictive value of that test is going to be very, very low. Therefore, most of the people with a positive test are going to be negative for the disease, and they have to go through some invasive tests and experience a lot of stress while they wait to find out the results. But what if you just took the women over the age of 50 that were at high risk for ovarian cancer and then just screened them for CA-125? There, the prevalence of the disease in that population is going to be a lot higher because you're narrowing the population to just those with a higher likelihood of the disease. And this will increase the positive predictive value of that test. You're not changing the test. It's just that how well a test predicts the presence or absence of disease is dependent on the prevalence of the disease in the population. Because of this, screening programs are more successful when they're targeting populations with higher prevalence of disease. All right, that's it for now. So let's go to your end of session quiz. Pause your video, answer those questions, and then turn back on your video so we can go through the answers together. All right, let's get started. What are the equations for sensitivity, specificity, positive predictive value, and negative predictive value? All right, one last time. Sensitivity is the true positives divided by the total of true positives plus false negatives. Specificity is the true negatives divided by the total sum of true negatives plus false positives. Positive predictive value is the true positives divided by the total sum of true positives plus false positives. And negative predictive value is the true negatives divided by the total sum of false negatives plus true negatives. So make sure you know those. We don't have rapid fire facts section in the study guide, but if we did, it would be those 4 equations, so know them. Next, what happens to positive predictive value of a diagnostic test when the disease prevalence increases? Remember that with increasing disease prevalence, you have increasing positive predictive value of a diagnostic test. And last one, a certain screening test has a 1% false negative rate. What's the sensitivity of this test? We didn't spend a lot of time on this, but we said that one of the equations for sensitivity is 1 minus the false negative rate, so the sensitivity of this test is 99%. And that's it for our lecture on diagnostic test evaluation. I'll see you next time.
Let's go over the warm-up review. First question, what histological findings of the distal duodenum are most likely seen in a patient with celiac sprue? So you're going to see blunting of the villi and hyperplastic crypts. And there will usually be lymphocytes in the lamina propria. Next, what are the branches of the celiac trunk? So the 3 branches that directly come off the celiac trunk are the left gastric artery, the splenic artery, and the common hepatic artery. And then the common hepatic artery gives off the gastroduodenal artery, the right gastric artery, and the proper hepatic arteries, which divides into the right hepatic artery and the left hepatic artery. The last one. A woman with a history of hypertension presents with sudden onset of sharp, tearing chest pain that radiates to the back. What's the most likely diagnosis, and what would be seen on a chest x-ray? So this is a classic description of an aortic dissection, and the classic chest x-ray finding would be widening of the mediastinum. So now we're ready for the lecture.
Welcome back. We're going to continue talking about evidence-based medicine and how we apply the results of our studies and testing in a practical way. I'm going to assume that you're watching these videos in order, and you've already seen the lectures on research study design and evaluation of diagnostic tests, because this lecture is going to build upon some of the concepts we covered there. One thing we touched on briefly in that video was the concept of disease prevalence and disease incidence. But let's define these terms in a little more precisely. This is pretty easy to understand, and it's also very high yield for your test. Let's start with prevalence, since we were just talking about how prevalence changes the positive and the negative predictive value of a test. What is prevalence? Prevalence is calculated by putting the total number of people in the population that have a certain disease in the numerator and putting the total population in the denominator. This gives you the proportion of the population with a certain disease at a given point in time. That is point prevalence. Say we are looking at the prevalence of COPD. We don't really care if the person has a newly diagnosed COPD or if they've had the disease for 15 years. All we care about is how many people in the population have COPD, period. But that is not true for incidence. Incidence only concerns itself with new cases in the population. So, to calculate incidence, you take the total number of new cases diagnosed over a given period of time, and you divide it by the total number of individuals at risk for the illness during that time period. So, incidence is concerned with the new cases, and prevalence is concerned with the total ongoing cases, old or new. With this in mind, you can see that some diseases will have a greater incidence than prevalence, and some will have a greater prevalence than incidence. Take COPD, for example. Only a few people are diagnosed with COPD on any given day. But when they are diagnosed, that diagnosis stays with them for the rest of their life. So the incidence may be low, but because it's a chronic disease, the cases just continue to build up. And this yields a high prevalence. What about an acute gastroenteritis, though? That's like your 24-hour stomach bug. That may only last a day or so, but can occur several times a year. So at any given point in time, there will be a lot of people with gastroenteritis, which means there's a high prevalence. But because people may get it more than once per year, you can see how the incidence, or the new cases within the given period of time, could really be high too. So one way to think about this relationship is that prevalence roughly equals the incidence multiplied by the disease duration. And because with chronic diseases and the disease course is very long, the prevalence of a chronic disease is greater than the incidence. For acute diseases, like the common cold or the stomach bug, the prevalence will roughly equal the incidence. One important thing to remember is that the incidence is the number of cases over a given period of time divided by the total population at risk. So when you're talking about COPD or some other disease, the population who already has the disease may not be in the new case, so they're not counted in the denominator. But they're also not at risk anymore because they already have the disease. So remember to correctly determine your population at risk when you're calculating your incidence. You need to really understand incidence and prevalence. This is a pretty basic concept and it is high yield, so make sure you understand the difference. Next, let's talk about the odds ratio and relative risk. This is also a 5-star topic. You're going to see questions about this. Both are going to be used to evaluate the results you get from our study. Let's start with relative risk. Remember that relative risk is calculated from cohort studies, which is where you're confirming risk factors. Relative risk is the probability of getting a disease in the exposed group compared to the probability of getting that disease in an unexposed group. Let's build another 2x2 table, just like we did for sensitivity and specificity. This is labeled slightly different. We still have disease written on the x-axis, but for the y-axis, instead of looking at a test result, we're now looking at some exposure, some risk factor. This table will help you determine the relationship between the risk factor and the disease outcome. This is another great marker board topic. It's definitely high yield for step 1, so it's important to understand these concepts and know the equations to calculate the odds ratio and the relative risk. So, what is the equation for the relative risk? It is A divided by A plus B all over C divided by C plus D. You are going horizontally here. These equations are the fundamental components of some other calculations. If you know A divided by A plus B and C divided by C plus D, we're going to use that as part of the equations for attributable risk and also odds ratio. We said that odds ratio is used for the case control studies, which are often used to identify risk factors. The equation for odds ratio is A over B divided by C over D. So the odds ratio compares the odds that someone will develop the disease in the exposed group to the odds that someone will develop the disease in an unexposed group. A over B divided by C over D. Now, you may see this equation written a little differently in some review books, where it's written A over C divided by B over D. But don't get confused. Both of those equations are actually correct. They are actually equivalent, although it may not seem obvious. A over B divided by C over D equals A over C divided by B over D. Try plugging in some numbers or working through some algebra. Prove to yourself. I promise they're equal. But here is another important thing to know. The odds ratio approximates the relative risk of the disease prevalence is not very high. So let's see if we can figure this out. How does the low prevalence affect A, B, C, and D? And what does that do to the relative risk calculation? If the disease prevalence is low, you're going to decrease A and C, and you'll increase B and D. Let's assume that the disease prevalence is so low that A and C become minuscule. If A and C become minuscule, how does the equation for relative risk change? Remember, the equation for relative risk was A over A plus B divided by C over C plus D. So if A is a tiny number relative to B, and then A plus B essentially just becomes B, right? If A is 1 and B is 1,000, there's not much difference between 1 over 1,000 and 1 over 1,001. So when prevalence is low, A over A plus B essentially becomes A over B. And when C is minuscule, C over C plus D becomes C over D. So when prevalence is very low, the relative risk equation becomes A over B divided by C over D. Then look back at the equation for the odds ratio. It's the same thing, A over B divided by C over D. So if you have the equation for a relative risk memorized, and you know the odds ratio approximates relative risk when the prevalence is low, then you'll know the equation for the odds ratio. Now, let's talk about attributable risk, which is slightly different. Attributable risk is the difference between the risk of disease among the exposed and the risk of the disease among the non-exposed. So this implies that there's a risk factor that is increasing the risk of the disease. There's an example in your study guide. It says that attributable risk is the incidence of disease in the exposed group minus the incidence of the disease in the unexposed group. For example, in a group of sexually active people, 30% have an HPV infection. In a population of people who are not sexually active, only 5% have HPV infection. Therefore, the attributable risk of sexual activity to HPV is 25%. This is an example of how you would have to calculate attributable risk on step 1. It's certainly not difficult as long as you know the concepts and remember the equations. Now, let's take a second to talk about absolute risk reduction. The absolute risk reduction equation looks a lot like the equation for attributable risk, but instead of looking at how much a risk factor increases the risk for disease, we're looking at how much a beneficial intervention will decrease the risk of the disease. In other words, A over A plus B becomes the proportion of people who have a disease from amongst all of those who receive the intervention, like a study drug. C over C plus D becomes the proportion of people with a disease out of the entire population that did not receive the intervention or study drug. So the calculation for absolute risk reduction is C over C plus D minus A divided by A plus B. We want to know the difference between the risk of the disease in the control group and the risk of the disease in the experimental group. If the risk of the disease without the drug is 10%, but the risk of the disease with the drug is 5%, then the absolute risk reduction is 5%. Let's go back to the study guide to discuss the numbers needed to treat. The number needed to treat, or NNT, is 1 divided by the absolute risk reduction. If you can calculate the absolute risk reduction, you can calculate the number needed to treat. The number needed to treat is the number of patients you would need to treat in order to save 1 life or to avoid 1 bad outcome. It's the number of people you would need to treat to get the effect you want to get in at least 1 person. This can be an important number to help you determine if a drug is cost effective. If you have a drug out there that is very small effect and you need to treat 1,000 people in order to save 1 life, the drug is probably not worth widespread use. We also use this number to evaluate clinical effectiveness of a drug. There's an example in your study guide. There are 100 acute stroke patients given TPA, a clot-busting drug, and 40 of them have a complete or near complete recovery. Now, there are 400 acute stroke patients not given TPA, and 80 of them have complete or near complete recovery. First, you calculate your absolute risk reduction, which is the risk of poor outcome without the treatment minus the risk of poor outcome with the treatment. Poor outcome was experienced in 320 out of 400 in the control group who were not given TPA, which is C divided by C plus D. A poor outcome was experienced in 60 out of the 100 in the group given the TPA, which is A divided by A plus B. So the absolute risk reduction is 320 divided by 400 minus 60 divided by 100, which is 0.2. To calculate the number needed to treat, you take the inverse of absolute risk reduction. That is, you calculate 1 over the absolute risk reduction, which is 1 divided by 0.2. This equals 5. Therefore, you need to treat 5 patients with an acute stroke to see the beneficial effect of TPA in 1 patient. There's also a similar concept called the number needed to harm, which I'll just mention briefly. Like I said, attributable risk is similar to the absolute risk reduction. It is just a measurement of the extra risk that is due to an exposure rather than decrease in the risk that is due to a beneficial intervention. So, as you may expect, the number needed to harm is similar to the number needed to treat. The number needed to harm is 1 divided by the attributable risk. Go ahead and look at your study guide again. What is the absolute risk reduction and the number needed to treat in the following example? In a study where 100 patients received medication Z to prevent the development of diabetes, and 200 patients did not receive the medication. 10 patients in the experimental group developed diabetes, and 40 patients in the control group developed diabetes. I want you to pause the video and try to work that out, and don't take more than 1 or 2 minutes and we'll go over it together. So the first thing to do is set up a 2 by 2 table. A is 10 because 10 people received drug Z but still got diabetes. We know that A plus B is 100 because that's the total number of subjects that were given the drug. So if A plus B is 100 and A is 10, then B must be 90. C is 40 because this was the number of people in the control group who developed diabetes. And then if the total number of subjects in the control group was 200, then D must be 160. So the equation is C divided by C plus D minus A divided by A plus B. This comes out to 40 over 200 minus 10 over 100, or 0.2 minus 0.1. So the absolute risk reduction with the study drug is 0.1, which is 10%. Then wait, what's the number needed to treat? Remember, the number needed to treat is 1 over the absolute risk reduction. Therefore, the number needed to treat in this question is 1 divided by 0.1, which is 10. Therefore, you need to treat 10 patients to prevent 1 case of diabetes. All right, this is all very high-yield stuff. Odds ratio, relative risk, attributable risk, absolute risk reduction, number needed to treat, number needed to harm, all 5-star topics. Now we're going to briefly cover precision and accuracy, also known as reliability and validity. So precision, or reliability, is the measure of how reproducible a result is. With a precise or reliable result, you get consistent results every time. So a precise test will not have a random variation and will therefore be reliable and reproducible. But the kicker is that precision does not necessarily imply that the reliable and reproducible results actually reflect the truth. That is where accuracy comes in. Accuracy, or validity, is a description of how closely the test results reflect the truth. With an accurate test, there may be variation in the results, but the variation will occur right around the true value. So you should remember the difference between reliability and validity. Validity is how accurate a test is, or how well it reflects the truth. And reliability is how reproducible the test is. Ideally, any test you would use to have the combination of precision and accuracy. All right, that's all we're going to cover in this video. So what I want you to do now is pause the video, answer the end of session quiz questions in your study guide, and then we'll go over those answers. Let's get started. What are the equations for odds ratio, relative risk, attributable risk, and number needed to treat? Odds ratio is A over B divided by C over D. Or another way to say this is A times D divided by B times C. This is the odds of having a particular disease in a group with risk factors divided by the odds of a particular disease without having the risk factors. Relative risk is A over A plus B divided by C over C plus D. This is the probability of acquiring a particular disease in a group with risk factors or exposures compared to a group without the risk factor or exposures. Attributable risk is the risk of developing a disease in a group with the risk factors minus the risk in the group without the risk factors. Or A over A plus B minus C over C plus D. And the number needed to treat is just 1 divided by the absolute risk reduction. And just like the last video, there aren't any rapid-fire facts, but make sure you know these equations and also the absolute risk reduction. Next, a small town of Breathless, population 8,000, is immediately adjacent to factories where asbestos products were produced. During the past year, the prevalence of mesothelioma has been 16 cases. The town of Clear Air, population 6,000, 15 miles upwind, and theoretically a safe distance from Breathless. There's a prevalence of 3 cases during that same year. So what's the relative risk of mesothelioma for the population of Breathless? The first thing you do is set up your table like this. The number of people with the disease in Breathless is 16, and the number of people with the disease in Clear Air is 3. The question didn't give you the number of people without the disease, but you don't really need it. All you need to know is A plus B and C plus D, since the equation for relative risk is A plus B divided by C over C plus D. So, 16 over 8,000 divided by 3 over 6,000, and that gives you 4. So the relative risk is 4. This risk of mesothelioma is 4 times higher in Breathless than it is in Clear Air. Next, a new glucose test arrives, and you decide to see how well it works. There's a standard substance provided that has 90 milligrams per deciliter of glucose. Your repeated measurements of the substance reveal the following values: 54, 56, 55, 54, 53, 56, 55, and 54. What can you say about the precision and accuracy of your new glucose test? You would say that this test is very precise since the results are all staying within a very narrow range of numbers. The results are very reproducible. But this is not accurate. The results aren't anywhere near what the true value is, which is 90. Last question. The prevalence of disease X in population A is 2 times the prevalence of disease X in population B. The incidence is the same in populations A and B. What can be assumed about the disease duration in population A versus population B? If the incidence is the same in both populations, but the prevalence is different, you have to assume the disease lasts longer in one population than in the other. So in this example, the duration of disease X is twice as long in population A as in population B. That's the end of session quiz, and that's the end of your lecture on application of test data. We'll see you next time.
It's time for another warm-up review. Let's get going. What are the risk factors for esophageal cancer? So for adenocarcinoma, which is more common in the United States, the major risk factors are GERD and Barrett esophagus, smoking, obesity, and diets high in nitrosamines. Now for squamous cell carcinoma, which is more common worldwide, the risk factors are smoking again, and also alcohol, diets high in the nitrosamines again, and then pre-existing esophageal pathologies like achalasia, esophageal webs, and strictures. Next, what is the most common benign salivary gland neoplasm? What is the most common malignant salivary gland neoplasm? And then what is the most common location for a salivary gland neoplasm? So what's the most common benign one? That's going to be your pleomorphic adenoma. And then when we're talking about malignant, you got to think about the mucoepidermoid carcinoma. And then the most common location, that's going to be the parotid gland. Next, which calcium channel blockers can be used to treat both hypertension and tachyarrhythmias? So think of diltiazem and verapamil. That's it for the review. Let's get to the video.
Welcome back. Let's continue our discussion of epidemiology and evidence-based medicine by looking at different threats to study validity that can potentially creep into a study design. We've just been talking about measures of effect, that is, how to measure the effect of an exposure or intervention in a research study. If we find a significant difference in outcomes, we now know how to calculate relative risk, absolute risk reduction, or number needed to treat. But something that we need to think about first is if the results are true or not. So there are a number of reasons why a study may show good results that are compelling, but that just don't reflect the truth. That is, they are not valid. Let me mention 3 things here that should always be considered. These are bias, confounding, and random error. Let's talk about bias. Now, when bias is used in casual conversation, it usually implies some sort of prejudice or lack of objectivity. For instance, we talk about somebody with a biased opinion. But in epidemiology, that's not an accurate description of bias. What we're talking about here is a flaw in the way a study is conducted or produces an outcome that's different from the underlying truth. There's some kind of systematic error in some phase of a study which results in a false association between the risk factor and the outcome. Bias can occur in any part of the study design, but is frequently seen during the selection of subjects, called selection bias, or during the collection of data, called information or observation bias. This systematic error or bias can make the effect of an exposure or risk factor on the outcome of interest appear stronger or weaker than it really is. It can go either way. So let's talk about different kinds of bias that we find in studies. I want you to follow along in your study guide while we go through this. Let's start with selection bias. Selection bias results when there is a systematic difference in the way the subjects are chosen that makes the study population different from the entire population that was eligible for the study. This is sometimes called sample selection bias. An example is in your study guide. The referral centers for a trial of a new anti-cancer drug have more patients with end-stage disease than early stage. So more patients with end-stage disease are referred than early-stage disease. So there will be a selection bias in the study. What we see here is that the referral pattern for the study is skewed toward end-stage disease. Therefore, study conclusions drawn from the data may not reflect the drug's effectiveness in all patients with this form of cancer. Now let's talk about a few specific forms of selection bias. There's Bergson's bias, also known as hospital patient bias. Bergson's bias results from using hospital patients rather than patients in the community as study participants. Because patients are hospitalized based on their exposure history, using hospitalized patients in a study can give skewed findings. The classic example was with DVT and birth control pills. Women with symptoms of DVT were more likely to be hospitalized if they were taking birth control pills because this was a known risk factor. So when the relationship between birth control pills and DVTs was studied using hospitalized patients, results were skewed due to the risk factor history contributing to the hospital admission in the first place. There's self-selection bias. This usually occurs because people who volunteer to take part in studies are different from those that don't. Your study guide says, in a study describing the association of a new drug with liver damage, a higher rate of liver disease was found among the patients that self-referred to the study than those who were solicited for the study through pharmacy records. If the reason that certain people self-refer to study population is also associated with the outcome of interest, then the results from the study may be biased. For instance, the people in the example may have self-referred because they were having symptoms that they thought could be due to liver disease. Another type of selection bias is the healthy worker effect. This occurs because the population of people who are actively working has lower disease and death rates than the general population. Your study guide says the harmful effect of a toxin exposure among active employees is underestimated because the control group is filled with people from the general population. So when a study population is chosen from an actively working population and then compared with the general population, the results may be biased. Now let's talk about information bias or observation bias, which is bias that occurs during the collection of data. First, recall bias. Recall bias results from a difference in recall between the two study groups. The example in your study guide says parents of autism patients having a more detailed recall of events and illnesses in their child's first 2 years of life compared with parents of healthy controls. When a child is diagnosed with autism or some other medical condition, the parents of those children often spend a lot of time trying to recall each and every event and exposure that occurred over the period of time prior to the diagnosis. When these parents are asked to recall details of their child's history, they will be able to give a very detailed, accurate description. When the parents of unaffected children are asked to provide a detailed history of the first few years of their child's life, it's very likely that they won't be able to provide the information with the same level of detail or accuracy. So this would result in recall bias. As I hope you can see from this example, recall bias has nothing to do with people intentionally misleading the investigators. It's only due to a difference in the accuracy and detail of the history. Next, lead time bias. Lead time bias results from early detection of disease. In some cases, early detection of disease is confused with increased survival. This frequently is seen with improved screening tests. What happens is that early detection of the disease increases the time that a person survives after diagnosis, even if the natural history of that disease is unchanged. The example in your study guide says while test PSA XYZ may detect prostate cancer before it's detected by a traditional PSA, early detection using PSA XYZ does not increase cancer survival compared to traditional PSA. So let's say the average survival after cancer detection by the old test was 15 years, and the new test is able to detect cancer 2 years earlier than the old test. So what you would see now is an average survival of 17 years after diagnosis. Does this mean that the new test and its associated early detection of cancer has somehow changed the natural history of the disease? Not at all. What you have here is merely an earlier diagnosis with absolutely no change in the natural history of that disease. All of the increase in survival is accounted for by additional lead time. So additional time is seen on the back end of the disease course. Now, late look bias. Late look bias is a bias that results from information being gathered too late to draw conclusions about the disease or exposure of interest in the entire intended study population. For example, sending out a survey to people diagnosed with a fatal illness 5 years after diagnosis. This study design will result in data collection primarily from those patients in the study group with low-grade disease or possibly those with fewer comorbidities. In order to capture the responses from the entire population diagnosed with the disease, it would be necessary to get that survey out to them immediately after diagnosis or as soon as the study would allow. Next, procedure bias. Procedure bias occurs when study groups within the same study aren't treated the same. The example in your study guide says the positive benefit of a new drug during a study simply may have been due to the fact that study participants were required to attend clinic monthly, where they received extra disease education and counseling compared with the controls. In order to avoid this, some investigators go to great lengths to try to get the control group in a given study to have the same amount of education, counseling, and medical care as the experimental group so that these variables don't contribute to a false association between the intervention and the desired outcome. Now, interviewer bias. This is similar to procedure bias. Interviewer bias occurs when the interviewer, who is obtaining information from the study population and the control population, treats those two groups differently, either in the questions that they're asked, the prompts that they give, or the way the information is recorded, or even in the way the answers are interpreted. Your study guide says an interviewer asks more questions about perceived symptom improvement to participants in the experimental group than in the control group. Okay, next is loss to follow-up. Loss to follow-up occurs when study participants no longer want to participate in a study and can't be contacted for follow-up. This can bias results if the dropout rate is very high, if there's an unequal dropout rate between the two study groups, or if those that drop out of the study are different from those that continue in the study. Your study guide says more people were lost to follow-up from the experimental group of a lipid treatment study than in the control group because of side effects of the experimental treatment. Next, Hawthorne effect. Hawthorne effect refers to the change in behavior from a study group that can result from the knowing that they are being observed. The example in your study guide says when studying the effects that infection control education has on physicians, the investigator notes that both the experimental and the control groups improve their hand hygiene. So what we see is that people who have been chosen to be part of an experimental or control group of a study, here a study on infection control practices, will change their behavior, at least in the short term, just as a result of them being observed, of being studied. This example of hand hygiene is actually fairly common. So let's talk about confounding. Remember that confounding was another reason, along with bias and random error, that significant study results might not be true. Confounding occurs when the association between the exposure and the outcome is distorted due to a third variable, which is associated with both the exposure and the outcome. I think this is much easier to understand when it's explained through an example. So in your study guide, it says, a very strong association was found between asbestos minors and lung cancer. It was then discovered that the minors also smoked more cigarettes than the control population. This is, again, a popular example for confounding. So if you're looking at the association of asbestos exposure and lung cancer, you will find that there's a very strong association between the two. But what might not be apparent unless the investigator knows to ask about it is that asbestos miners are more likely to smoke than the other populations that may be chosen as controls. So when an investigator is looking at lung cancer rates in asbestos workers, they may attribute all of the increased risk of lung cancer to the asbestos exposure, when tobacco use is also playing a role. So you can see here that confounding is occurring because tobacco use is a third variable that's associated with the exposure, that's asbestos mining, as well as the outcome, lung cancer. So unless you know about this potential confounder and then control for it in the study, then you may end up with a distorted association between asbestos mining and lung cancer. Okay, so now we've talked about bias and confounding. Now, the third reason that significant study results may not be true is if the results occurred as a result of pure chance. Unlike bias and confounding, which are due to systematic errors in the study design or methods, random error can't always be avoided. Sometimes it just happens during sampling when the groups are different just because of chance. So now that we know about bias, confounding, and random error, what can we try to do to prevent them? Well, these errors at some level are inevitable. There's no perfect study out there, but there are ways that investigators can reduce these errors in their studies and thereby increase the validity of the study. You may have heard of randomized, double-blinded, controlled trials. Well, these words, randomized, double-blinded, and controlled, are all used to describe the ways that a study can be designed to reduce bias and confounding. So let's talk about these methods for a moment. Let's begin with randomized. Randomization means that the trial has randomly assigned members of the study population to either the experimental or the control group, which implies that each person in the study population had an equal chance of being chosen for either the experimental or the control arm. This random selection helps limit selection bias and also controls for confounding, since one would hope that the random assignment of study subjects results in the two groups having a similar baseline characteristics. Okay, so that's the randomized part of a randomized double-blinded controlled study. So let's talk about double-blinding. A double-blinded study is one in which neither the study participants nor the physicians or researchers interacting with them know which ones are part of the experimental arm and which ones are part of the control. In this way, the expectations of the participants and the researchers are less likely to affect their evaluation of the study intervention. Okay, so that was the double-blinded part of a randomized, double-blinded controlled trial. So now let's talk about the controlled aspect. A controlled trial means that there are at least two study arms, one with the experimental intervention and one with the control intervention or placebo. The control arm allows the experimental intervention to be compared with a placebo or a known established treatment in a study group that's otherwise similar to the experimental group. One rather inventive way of creating a control group is seen in a crossover study. In a crossover study, you have patients serving as their own controls. I don't think you can get better than this, really. So for one period of time, the study subject receives the experimental intervention, and for another time period, the same study subject gets the control intervention or the placebo. And this helps limit bias in the selection of experimental and control study groups and helps limit the effects of confounding. All right, so that's all I'm going to say about bias, confounding, and random error. Now let's go over the end of session quiz. So I want you to pause the video, go through those questions, and turn back on your video so we can go through the answers together. Okay, what is bias? It's a systematic error in the way a study is conducted that results in a false association between the risk factor and the outcome, or outcomes that differ from the underlying truth. What are some ways investigators can reduce bias in a study design? Well, randomization, double-blinding, and using a control group. What is confounding? It's when the relationship between an exposure and an outcome is distorted, either magnified or reduced due to a third variable that's associated with both the exposure and the outcome. That's the end of our end of session quiz, and that's the end of our lecture on study validity. I'll see you next time.
It's time for another warm-up review. Let's get going. What rectal diseases are found proximal to the pectinate line, and what diseases are found distal to the pectinate line? So proximal to the pectinate line, you would see adenocarcinoma, so we're talking about colorectal cancer, and then also internal hemorrhoids. Now distal to the line, you can see squamous cell carcinoma, which would be anal cancer, and also external hemorrhoids. Next, which antihypertensive drug has each of the following side effects? So first dose, orthostatic hypotension, those are going to be your alpha-1 blockers, so these Zosyn drugs. Also, clonidine can do this, which is an alpha-2 agonist. Hypertrichosis, that's going to be minoxidil. Remember, minoxidil is Rogaine, if you've heard of that over the counter. Cyanide toxicity, that's going to be nitroprusside. Dry mouth, sedation with severe rebound hypertension, think of clonidine. Next, during a high school football game, a young athlete collapses and dies immediately. Which type of cardiac disease would you suspect? This scenario should make you think of hypertrophic cardiomyopathy. That's it for the review. Let's get to that video.
Hi, welcome back. Now let's talk stats. First, we're going to talk about statistical distribution. This is definitely an important concept, at least a 4-star topic. I would expect you to have a question about this. So right up front, let's talk about a few statistical terms, specifically mean, median, and mode. Mean is the average of all the values. The median is the value that falls right in the middle of all the values, where half of the values fall above it and half the values will fall below it. And the mode is the value that occurs most commonly. So as you can see from their definitions, these values may be very different from one another on some distribution curves. However, when you're talking about a normal distribution, also known as Gaussian or bell-shaped distribution, what you find is that the mean is equal to the median is equal to the mode. But I want you to remember that the mean equals median equals mode only happens with a normal distribution, where the distribution of values follows a perfect bell curve. Obviously, this is a rare occurrence. There is usually some variation of distribution occurring. One variation is called a bimodal distribution, where the values form 2 humps. So a bimodal distribution has 2 humps or 2 modes that provide a visual clue that the study participants are falling into 2 different groups. If you're studying a drug and the study results show a bimodal distribution, you might be looking at one group where the drug is effective and one group where the drug is not effective. If you're looking at a lab result, you might be looking at one group where the lab result is positive and one group where the lab result is negative. If you're looking at test scores, you might be looking at one group who actually attended all of the classes and understood the information, and the other group who didn't attend all of their classes and didn't get the information. So you have 2 main categories or groups of people. Another way that the distribution curve can vary from the perfect bell curve is that it can be skewed. Now, I want you to remember what I'm saying here about a skewed curve. A positive skew is where the distribution curve is asymmetric and has a tail to the right of the curve. In this situation, the mean is greater than the median, which is greater than the mode. It may help you to think of an amoeba sort of moving in the positive direction. So this is a positive skew. A negative skew is found with an asymmetric curve with the tail on the left. With a negative skew, the mean is less than the median, which is less than the mode. Again, a negative skew has a tail to the left. This is pretty simple stuff, and it's important to know for step 1. So be sure that you can recognize a positive and a negative skew and know the difference between mean, median, and mode. All right, now let's move on to statistical hypotheses. Statistical hypotheses, error types, and power are all high-yield topics. We would give this information 5 stars, really important for step 1. You'll probably have 2 or 3 questions on this stuff, so try to really take in this information. Now let's begin this section by talking about why we would even perform a scientific study. Well, usually what happens is that someone makes an observation and forms a hypothesis, but they don't know if their hypothesis reflects reality. They don't know if the drug in question has real benefit or if a certain exposure is truly a risk factor for disease. So studies are performed to try to discover true effects of exposures and interventions. Unfortunately, studies have bias and error, many different kinds of bias and error, so they don't always reflect reality. And this is why it's important that we understand study design and study error so that we can critically evaluate scientific studies and determine how well they reflect truth. One way to evaluate test results and how well they reflect truth is through hypothesis testing. The first step in hypothesis testing is outlining the null hypothesis and the alternative hypothesis. The null hypothesis, which is designated by a capital H and a subscript 0 or H naught, states that there's no association between the exposure and the outcome or disease. In other words, the null hypothesis is just saying that something is not related to something else. On the other hand, the alternative hypothesis, designated by a capital H and a subscript 1, or H1, states that there is indeed an association between the exposure and the outcome or disease of interest. The original assumption in hypothesis testing is that the null hypothesis is true. Therefore, it is left to the investigator to reject the null hypothesis using the study data. So after outlining the null and alternative hypothesis and acquiring the study data, the investigator then analyzes the data and judges the compatibility of the study data with the null hypothesis. The type of statistical test used by the investigator depends on what type of data were acquired in the study, and we'll discuss some possible statistical tests later. But suffice it to say that the p-value is the value of interest at this point in hypothesis testing. The p-value lets us know how compatible the study data are with the null hypothesis. So a very small p-value indicates that it's very unlikely that the study values occurred as a result of chance alone. So very small p-values are not compatible with the null hypothesis. With a very small p-value, you cannot say that there's no association between the exposure and the outcome of interest, and that all of those observed results were merely due to chance. This then leads us to the third step of hypothesis testing, which is when the investigator decides whether he can reject the null hypothesis. In most studies, the investigator chooses a value of 0.05 as the p-value cutoff for determining whether or not it's reasonable to reject the null hypothesis. If the p-value is less than 0.05, the investigator will usually conclude that it's not reasonable to assume that the null hypothesis is true. So they formally reject the null hypothesis and accept the alternative hypothesis that indeed there is an association between the exposure and the outcome of interest. Now, let's discuss error types that are associated with hypothesis testing. We'll be discussing type 1 error, also known as alpha error, and type 2 error, also known as beta error. Type 1 error occurs when the investigator rejects the null hypothesis and accepts the alternative hypothesis, when in reality there is no association between the exposure and the outcome. So it might help you to think of this as a false positive error, because the investigator said there was an association when there really wasn't. A type 2 error occurs when the investigator accepts the null hypothesis that there is no association between the exposure and the outcome, when in reality there is an association. It might help you to remember this as a false negative error, because the investigator said there was not an association when in reality there was. Say you were doing a study that was looking at smoking as a risk factor for lung cancer. If your data analysis gave you a p-value of 0.1, you might accept the null hypothesis and say that there's no association between smoking and lung cancer. This would be an example of type 2 or beta error. One way to visualize this information, which might help you remember it, is to put it into a 2x2 table. Across the x-axis is written reality, wherein you put the values that reflect the true state of the situation. The two columns are labeled H1 and H0. Then along the y-axis is written study results. The two rows are labeled H1 and H0. In the top right box, you can fill in alpha. This is where a type 1 error or alpha error would occur. That is, when the study analysis shows an association between the exposure and the outcome, but the reality is that the association does not exist. Now, you would fill in a beta into the bottom left box. This is where a type 2 or a beta error would occur. That is, when a study analysis does not show an association between the exposure and the outcome, when in reality an association does exist. In the top left corner, you would fill in the word power, or 1 minus beta, because the power of the test is equal to 1 minus the probability of the type 2 error. We'll discuss more about power in just a few minutes. But first, let's talk about the p-value. What is p? Well, like I already mentioned, the p-value lets us know how compatible the study data are with the null hypothesis. In other words, if the p-value is high, it supports the null hypothesis. If the p-value is very low, it does not support the null hypothesis. How do we judge if the p-value is high or low? Well, we use a cutoff value called the alpha level. Now, the alpha value is set by the investigator prior to the beginning of the study as a measure against which the p-value is judged. In medical studies, an alpha value of 0.05 is usually used. It's an arbitrary number chosen by the investigator, and it could be some other number. But the convention in medicine is that an alpha value of 0.05 is good, and most of us are comfortable with this cutoff. Now, the p-value is calculated from the data set and then that calculated p-value is compared with the chosen alpha value of 0.05. If the p-value is less than that cutoff value of 0.05, then the null hypothesis is rejected, the alternative hypothesis is accepted, and the results are usually designated statistically significant. Now, if the p-value is greater than 0.05, then the null hypothesis is not rejected, and the results are said to be not significant. Just so you know, this p-value stuff is pretty important. So be sure to remember what the p-value represents and how it's used to determine the significance of study results. Okay, now let's talk a little bit about power. Power refers to the probability that a test will correctly reject the null hypothesis when it's indeed false and the alternative hypothesis is true. What affects power? Well, there are many variables involved, but there are a few that are intuitive. The investigator needs to know what the expected outcomes are in the control group and the magnitude of effect that they expect to see in the experimental group. So if they expect that the magnitude of effect resulting from an intervention is going to be very small, they're going to need more participants in order to convincingly demonstrate that difference. If the magnitude of effect is expected to be very large, then the investigators can include fewer participants to adequately show an effect and thereby allow for the rejection of the null hypothesis. If the investigator expects a lot of people to drop out of the study or be non-compliant because of side effects, then this also needs to be taken into account when trying to power a study correctly. By increasing the number of study participants, the investigator can increase the power of the study. The more people that are included in the study, the more likely the results will reflect reality. However, with additional study participants comes increased expense, increased time, and more effort. So there needs to be a balance. In my medical school class, there was a bunch of guys involved in a research study of the lipid effects associated with drinking wine versus grape juice. And they were all in the grape juice arm, and they were drinking liters of grape juice every day. And of course, they all developed terrible diarrhea, and they all dropped out of the study. So I hope that investigator knew to increase the number of participants in order to account for participants dropping out. That grape juice study always comes to my mind when I'm thinking about how to power a study. I sure hope that investigator knew what they were doing. All right, complex stuff, but very high yield. And there's just one more video on statistics, so we're almost there. For now, go ahead and pause your video, go through the end of session quiz, and then turn your video back on so we can go through the answers together. All right, let's get started. First question. Study X shows that vitamin C can prevent coronavirus infections, but 10 other studies show no benefit. What type of error is found in Study X? Well, this is type 1 error or alpha error. You're finding an effect that does not really exist. Okay, next. Study Y shows that aspirin administration during an MI offers no improvement in patient morbidity or mortality. What type of error is present? Well, this is a type 2 error or a beta error. You're finding no effect or no difference when in fact an effect does exist. Next, what's the difference between the mean, the median, and the mode? Remember, mean is what we usually call the average, where we add up all the values and then divide by the number of values. Median is that middle value, taking into consideration the frequency of the distribution so that half of the values are above the median and half the values are below the median. And then the mode is the most frequent value, the one that turns up most frequently. Next, what does it mean to say that a statistical distribution has a positive skew? Well, a positive skew means that instead of a normal Gaussian distribution, the curve is shifted to the left with a tail to the right, so that the mean is greater than the median, which is greater than the mode. And that's the end of our end of session quiz. That's the end of our lecture on statistical distribution and error. I'll see you next time.
Let's start with the warm-up. First question, what histological findings are seen in alcoholic hepatitis? So fatty infiltration is a common finding, although it's not specific for alcoholic hepatitis. NAFLD and NASH can also cause fatty infiltration. You can see Mallory bodies, which are intracytoplasmic eosinophilic inclusions, but again, these are not specific for alcoholic hepatitis. They can also be seen in alcoholic cirrhosis, Wilson's disease, primary biliary cirrhosis, and hepatocellular carcinoma. But they're most commonly seen in patients with alcoholic liver disease. Then you might also see necrosis and swelling of the hepatocytes. Next, why is cough one of the common side effects of ACE inhibitors, but not angiotensin receptor blockers. ACE inhibitors and ARBs both act on the renin-angiotensin-aldosterone system, but they act at different points in the pathway. ACE inhibitors work by inhibiting angiotensin-converting enzyme so that there's less angiotensin II circulating. But angiotensin-converting enzyme also breaks down bradykinin. So when you inhibit angiotensin-converting enzyme, there's more bradykinin circulating, and that can cause that nagging cough. Now, ARBs don't cause a cough because they don't inhibit angiotensin-converting enzyme. So bradykinin levels are going to remain normal, and angiotensin II levels remain normal as well. But ARBs block the angiotensin receptors. So that's it for the warm-up. Let's go ahead and get started with the lecture.
This is the last lecture on research studies in epidemiology and biostatistics. And we've already covered a ton of extremely high-yield 4- and 5-star topics. But this video is no different. Let's start with standard deviation and standard error. This is another high-yield section. Specifically, I think it's important to understand the concept of a normal distribution, standard deviation, and standard error. So let's go over that now. A normal distribution, or Gasson distribution, looks like the perfect bell curve. With this distribution, one standard deviation on each side of the mean contains 68% of the population. Two standard deviations on either side of the mean contain 95% of the population. And three standard deviations on either side of the mean contain 99.7% of the population. That's nearly 100%. So these are numbers I think would be good for you to know. 68, 95, and 99%. So what is standard error of the mean? If we say that n equals sample size, sigma equals standard deviation, and SEM equals standard error of the mean, then we calculate SEM equals sigma over square root of n. This equation will be important for calculating your confidence intervals in just a moment. So just looking at the equation, you can see that you get the SEM by dividing the standard deviation by something. Because of this, you would expect the SEM to be less than the standard deviation. Another thing you can see by looking at this equation is that SEM decreases as n increases, which makes sense. The standard error of the mean goes down as you increase your sample size. One thing you need to recognize here and remember is that there is a difference between the standard deviation and the standard error of the mean. They sound kind of the same, but don't confuse them. The standard deviation describes the variation of values within one sample of the population. The standard error describes the variation of the sample means from that of the true population mean. So you need to know that these represent two different numbers, but that they're both used to calculate the confidence interval. Okay, so then what is the confidence interval? Let's say you performed a study on a sample of 1,000 people. In that study, drug X increased life expectancy by 6 months. Now, what would happen if you repeated that exact same study, where you sampled another 1,000 people? Well, chances are you would obtain a slightly different result, but it shouldn't be too different, right? Well, what we're talking about here is the confidence interval. Now, when you designed that study, I'm sure you were careful to plan it well, so you would be very confident that the final calculation of increased life expectancy would be a good approximation of the true value. But because the study was done one more sample of the population and not the entire population, it's unlikely that it is the true value. Obviously, it would be impossible for us to put the entire population through the study to try to determine the true value. So the confidence interval is the range of values within which we would expect to find the true value if we were to sample the entire population. Now, the confidence interval can be calculated to reflect different levels of confidence. If you wanted to be 90% confident that the true value was contained within the confidence interval, then the confidence interval would contain fewer numbers. That's to say, the interval could be narrower. If you wanted to be more confident that the true value was contained within the interval, you would want to increase the confidence level to, say, 99%. This would cause the range of numbers to be broader in order for it to include the possible values. Now, let's take a look at how we determine the confidence interval. Well, the equation for confidence interval, or CI, is CI equals the mean minus Z times standard error of the mean, 2, mean plus z times standard error of the mean. So what is z? Z is a constant that's specific to the confidence interval, and you're trying to calculate. If you want to set your confidence interval at 90%, then you would use z of 1.645. If you want to calculate to 95% confidence interval, then you would use a z of 1.96, which you could round to 2 for simplicity's sake. If you want to calculate a 99% confidence interval, then you would need to use a z of 2.57. You can see that as you increase your confidence intervals from 90 to 95 to 99, your z value would increase from 1.645 to 1.96 to 2.57. Because of z's place in the confidence interval equation, you will see that as your confidence level goes from 90 to 95 to 99%, the confidence interval itself becomes broader and broader. So, just to reiterate, how do we calculate the confidence interval? CI equals mean minus z times standard error of mean to mean plus z times standard error of mean. And again, what is z? It depends on the range you want to calculate. For a 90% confidence interval, use a z of 1.645. For a confidence interval of 95%, you would use a z of 1.96, or 2 to make it simple. If you want to set a confidence interval of 99%, you would use a z of 2.57. Let's look at this confidence interval in an example. Say there's a study that takes a group of middle-aged men and randomly assigns them into one of 2 groups. Group A is given a strict, low cholesterol diet. Group B is a control group, where each person eats whatever they would eat in a normal day. Those on Diet A have 5 cardiac events per 1,000 persons years. Those on Diet B have 7 cardiac events per 1,000 person years. Now, what is given here is the rate of adverse outcomes in the exposed group and the unexposed group. Now, we can compare these rates in different ways. We can use a rate or risk difference, where we subtract the rate of the unexposed from the exposed. Show the equation RD equals RE minus RU. In this case, the risk difference would be 5 minus 7, which equals -2. So in this case, exposure to the new diet decreased the incidence of cardiac events compared to the control group. So the rate difference is less than 0. This demonstrates a favorable impact of the exposure. By this measure, it looks like the diet is a great protector against cardiac events. So what if we calculate a 95% confidence interval, and it shows a confidence interval of -5 to 1? What does this tell us? It tells us that we are 95% certain that the true value of the difference in rate is somewhere between -5 and 1. So what's the problem here? Do you see how the confidence interval crosses 0? So this is telling you that the true difference between the rates will either be in the positive or negative direction. It could just be 0, where there's no difference at all in the 2 groups. The rate of adverse events was the same in the exposed group and the unexposed group, indicating that the study intervention did not affect the outcome. When we say the study intervention has no effect on the outcome, what are we saying? We're saying we have to accept the null hypothesis, that there is no association between the intervention and the outcome. Now, what if the study outcome is the same, but we decide to use a rate or risk ratio instead of a rate or risk difference? In this case, the equation is RE divided by RU. When we do this, the rate or risk ratio is 5/7, or 0.7. So, the rate of adverse outcomes is less in the exposed than in the unexposed. Then, the rate ratio will be less than 1. If the risk is greater in the exposed than in the unexposed, then we will have a rate ratio greater than 1. Now, what if the rates of adverse outcomes were exactly the same in the exposed and unexposed groups? This leads to a ratio of 1 and supports the null hypothesis. What if you were to calculate the confidence interval of this rate ratio and saw that 0.3 to 1.7? what would you conclude? Well, if you're calculating a confidence interval for a risk or rate ratio, and the confidence interval crosses 1, then you conclude that there is a reasonable chance that there is a true value of the rate ratio or risk ratio is 1. If there is a reasonable chance that there is no difference between the two groups, then an investigator cannot reject the null hypothesis, and this study would have to conclude that the study data did not show an association between the exposure or intervention and the outcome. Before we go any further, let's work through some practice questions together in the study guide. What's the equation for determining confidence interval? The confidence interval is equal to the mean plus or minus z times the standard error of the mean. Now, what is z? It depends on which confidence interval you're trying to calculate. For a 90% confidence interval, z is 1.645. For a 95% confidence interval, z is 1.96. And for the 99% confidence interval, z is 2.57. So how do we calculate SEM? SEM is equal to the standard deviation divided by the square root of the sample size of the study. You need that to answer question 6. In a study of USMLE scores at a particular medical school, the mean score from a random sample of 100 students is 230, and the standard deviation is 20. Calculate the 95% confidence interval. Here, the SEM, or standard error of mean, equals the standard deviation divided by the square root of the sample size. So that would be 20 divided by the square root of 100, or 20 divided by 10, which is 2. So the SEM equals 2. And here we are going to round z to z of 1.96 up to 2 in order to simplify the calculation. So again, the formula for confidence interval is the mean plus or minus z times the SEM. So we have 230 minus 2 times 2, or 230 minus 4, which is 226. On the other side, we have 230 plus 2 times 2, or 230 plus 4, which is equal to 234. So the confidence interval for this study is 226 to 234. Okay, so the next two questions are related to the previous. What is the 99% confidence interval in this same study? So we're going to use the same standard error of mean, which was 2, and the same mean score of 230. But instead of calculating a 95% confidence interval, we'll be calculating a 99% confidence interval. So instead of using 2 as our z, we're going to use 2.5. You remember that the formula for confidence interval is the mean plus or minus z times SEM. So we have the 230 minus 2 times 2.5, or 230 minus 5, which is 225. On the other side, we have 230 plus 2 times 2.5, so that makes it 230 plus 5, which equals 235. So the 99% confidence interval for this study is 225 to 235. So what this is trying to reiterate to you is that as you increase your confidence level, you'll widen your confidence interval. Next. In a study of USMLE scores at a particular medical school, the mean score from a random sample of 16 students is 230, and the standard deviation is 20. Calculate the 95% confidence interval. Okay, so first we need to calculate the standard error of mean. To get the standard error of mean here, take the standard deviation divided by the square root of the sample size, which is 16. So we take the standard deviation of 20 and divide it by the square root of 16. That becomes 20 divided by 4, which equals 5. So the standard error of mean is 5. Now again, I want you to remember that the formula for confidence interval is the mean plus or minus z times SEM. We'll be using a z of 2 since we're calculating the 95% confidence interval. So now we have 230 minus 2 times 5, or 230 minus 10, which is 220. On the other side, we have 230 plus 2 times 5, or 230 plus 10, which is 240. So the 95% confidence interval of this sample of 16 students is 220 to 240. So what we're trying to reiterate to you here is that a smaller sample size, the confidence interval will broaden. When you have a larger sample size, your confidence interval for a given confidence level will be more narrow. All right, The rest of the material I'm going to cover in this video is not as high yield as the other statistics topics that we've already covered, but they are still fair game for step 1, and they show up on the test from time to time. So let's take a little bit of time to go over them. First up is the t-test. The student t-test is a way to compare means of two groups when the study data are continuous variables. So if you're comparing the average weight of men versus the average weight of women within a certain population. Weight is a continuous variable, and the mean can be calculated. A t-test can then be used to compare the means of two groups, and that's really all you need to know about a t-test. ANOVA is basically the same thing as a t-test, but it can be used to detect differences between the means of different groups that use continuous variables. But instead of looking at two groups, you're looking at any number of groups greater than 1. ANOVA stands for Analysis of Difference, and it's used to detect a difference between the means of 2 or more groups. It's like a more complicated t-test. The chi-square test can be used to determine the difference between percentages or proportions of categorical outcomes, not mean values, and 2 or more groups. Anytime you look at a study and see 2x2 table, 2x3 table, or 3x4 table of data points, think of a chi-square analysis. The t-test and ANOVA are used to analyze the mean values of continuous variables. The chi-square is used to evaluate categorical or discrete variables like male versus male, disease versus no disease, defined age groups like 15 to 20, 20 to 25, 25 to 30, etc. These are all categorical variables in which can be evaluated using the chi-square test. Okay, now let's look about the correlation coefficient. The correlation coefficient, designed by a small r, looks at two variables in your study and determines the relationship between those two variables. So you might be looking at the prevalence of smoking and the incidence of lung cancer. You may notice that as the prevalence of smoking goes up, the incidence of lung cancer goes up. This would be a positive correlation, because as the x increases, the y increases. Now, say you're looking at a physical fitness and coronary artery disease. You might notice that physical fitness increases, the incidence of an MI decreases. This would be a negative correlation. As x increases, the y decreases. So, the correlation coefficient can be calculated to measure the relationship of those variables to each other. The value for the correlation coefficient will fall somewhere between 1 and -1. The closer the absolute value of the coefficient is to 1, the stronger the correlation between the two variables. An R of 1 indicates perfect correlation between the two variables, whereas an R of 0 indicates that there is no relationship between the two variables. If the correlation coefficient is greater than 0, that is, a positive number, then the relationship is a positive correlation. If the correlation coefficient is less than 0, or a negative number, then the relationship is a negative correlation. And again, the correlation coefficient is 0, then there is no correlation at all between the two variables. So the correlation coefficient, or R, describes the strength and direction of relationship between two variables. Now there is a related term called the coefficient of determination, or R squared. This is a measure of goodness of fit. What the R squared value does is describe how well the statistical model or regression line reflects the actual data or observed values. So again, R squared describes how good of a fit there is between the study model or regression line and the observed data points. This R squared value, the coefficient of determination, is the one that you will see more frequently reported in published studies. All right, I think we have finally reached the end of this lecture. I hope it wasn't too overwhelming. The good news is, just by listening to what was said here and doing those study guide problems, you've been exposed to a lot of high-yield information for your Step 1 test. So what I want you to do now is pause the video, answer your end-of-session quiz questions, and then restart the video, and we'll go over the answers together. Okay, let's go through these answers. First question. In a normal Gaussian curve, what percentage of the sample population follows 1 standard deviation, 2 standard deviations, and 3 standard deviations from the mean? 1 standard deviation is 68%, 2 is 95%, and 3 standard deviations is 99.7%, practically 100%. Next, what's the equation for determining the confidence interval? confidence interval equals the mean plus or minus z times standard error of the mean. Next, in the study of a diabetic patient on drug Sugadunk, the average patient hemoglobin A1C after 3 months is 8, and the standard deviation is 0.5. Knowing that the sample size is 10,000, calculate the 99% confidence interval. So, you have your equation for confidence interval on the question above. So first, we need to calculate the standard error of mean. Standard error of mean equals the standard deviation, which we're given, divided by the square root of the sample size, n. So the square root of 10,000 is 100. Standard deviation divided by 100 equals 0.005. So the standard error of the mean is 0.005. And you might think, wow, that's a pretty small number. That's not much error. That's because the sample size is just huge. So go back over your equation for confidence interval. We're given the mean, and now we have the standard error of 0.005. And for a 99% confidence interval, the z is approximately 2.5. So z times SEM is 2.5 times 0.005, which is 0.0125. So the 99% confidence interval would be 8 plus or minus 0.01225. And that is it for the end of session quiz. And that's the end of this lecture on confidence interval. We'll see you next time.
Hello everyone, it's time for another warm-up. Let's get going. First question here, which hormones stimulate pancreatic secretions? First we have acetylcholine, that's going to be via the vagus nerve. We have cholecystokinin, and then we have secretin, and that's going to stimulate the pancreatic duct cells to generate a lot of bicarb secretions. Next, what are the equations for odd ratio, relative risk, attributable risk, and number needed to treat? So odds ratio is going to be A over B divided by C over D. Or you can say AD divided by BC. Or then again, another way of writing the same thing is going to be A over C divided by B over D. Next, we have relative risk. That's going to be A over A plus B divided by C over C plus D. Attributable risk, A over A plus B minus C over C plus D. And then the number needed to treat is 1 over the absolute risk reduction. All right, guys, that brings us to the end of the warm-up. Let's get to that lecture now.
In this video, we're going to discuss disease prevention and public health. So we talk about disease prevention throughout the course with the individual diseases, of course, but we want to focus in on a few topics that we don't cover elsewhere, like vaccines and accident prevention. So let's start the disease prevention section by going through some definitions. So primary prevention is prevention of disease that hasn't occurred. So an example would include a vaccination to prevent an infectious disease, or encouraging condom use to decrease the risk of HIV transmission. So primary prevention is where you make or recommend an intervention to prevent a person from developing a disease. Secondary prevention is early detection or treatment of disease to prevent disease progression. So think about breast cancer screening with mammograms. Mammograms don't actually prevent breast cancer. That patient with that spiculated lesion already has breast cancer, but the mammogram allows you to detect it at an early stage in order to prevent progression and morbidity. So also in this category would be treatment of a chronic disease like hypertension to prevent long-term effects. You can think of preventing an asymptomatic disease from becoming symptomatic. So tertiary prevention focuses on patients who already have a symptomatic disease and addresses measures to reduce disability from the disease. This is different from secondary prevention, which aims to prevent the disability. So again, the patient already has the disease, but we're trying to keep him or her as healthy as possible. An example would be prescribing prophylactic antibiotics for AIDS patients like Bactrim to prevent PCP. The antibiotic doesn't prevent the HIV from progressing, but it can help limit the overall burden of disease by preventing PCP. And then quaternary prevention is sort of a new name for an old concept. First, do no harm. The idea that patients can be harmed by overdiagnosis and overtreatment, and we want to avoid that by not recommending potentially harmful things. So for example, a patient gets unnecessary antibiotics for a viral infection and then has a serious reaction to the unnecessary antibiotic. This could be avoided by not giving the antibiotic. Another example is causing patients undue stress by ordering too many tests. So quaternary prevention is judicious and evidence-based use of medical interventions in order to avoid unnecessary risk to patient. So I mentioned vaccination as a form of primary prevention. And for step one, you need to be familiar with the various vaccines that are available and what diseases they prevent. And you need to be somewhat familiar with when these vaccines are given. So you don't need to memorize specific vaccine schedules, but you should be generally familiar with them. More than the schedule, you'll need to know the diseases that are vaccine preventable. So for most vaccines, it's pretty straightforward which disease they aim to prevent. It's just the vaccine name itself. But some are potentially tricky. And know that when I use the word prevent here, we all know that these vaccines do not prevent 100% of the cases of diseases they vaccinate against. That's the language I'm going to use, though, for brevity. So, okay, let's start with the routine childhood vaccines in the study guide. So there's a rotavirus vaccine that prevents rotavirus, which is a severe diarrheal illness in infants and young children. The diphtheria, tetanus, and pertussis vaccines are a little more confusing because there are several combinations given to different groups and the names are similar. These vaccines prevent diphtheria, tetanus, which is also called lockjaw, which is caused by Clostridium tetani, and pertussis, which is commonly called whooping cough or whooping cough, depending on where you're from. The first two vaccine combinations are the DTaP, diphtheria, tetanus, and acellular pertussis, and the DT, which is just diphtheria and tetanus. These are given to infants and children under the age of 7. You generally use DTaP, but the DT vaccine is for children who can't tolerate the pertussis component. Next are the Tdap, that's tetanus, diphtheria, and acellular pertussis, and the T(d), tetanus and diphtheria. So the lowercase d and p in the Tdap indicate a lower dose of the diphtheria or pertussis component in these vaccinations. The lowercase a just stands for acellular. The Tdap is given as a booster shot in adolescents, unless the pertussis component is contraindicated, in which case you just give T(d). And the T(d) is what we use for a tetanus booster shot every 10 years or whenever your patient steps on a nail or whatever. The next vaccine is Haemophilus influenza type B, which I'm going to call Hib or H-flu. This is where the disease prevented gets a little trickier because this organism, H-flu, can cause meningitis, epiglottitis, osteomyelitis, pneumonia, bacteremia, septic arthritis. So on your exam, they might give you a patient with epiglottitis, which they love to test on for some reason, and then they ask you which of the following vaccines could have prevented this disease. So you have to know the presentation of epiglottitis and know that it's often caused by H-flu. So next is the pneumococcal vaccine, and there are two different variations. There's the pneumococcal conjugate vaccine, or PCV13, which covers 13 pneumococcal serotypes. This is given to infants and toddlers, and it creates better immunogenicity of the two. There's also pneumococcal polysaccharide vaccine, or PPSV23, that covers 23 pneumococcal serotypes. So this one is a bit less immunogenic, although it still works, but it covers more strains. So the PPSV23 is given to adults 65 and older, but there are certain instances where children over the age of 2 can receive the PPSV23, such as kids with chronic heart disease or lung disease like asthma, or kids with diabetes, or asplenic kids like sickle cell patients, or immunocompromised kids, including kids with HIV. So some kids will receive both pneumococcal vaccines, the routine conjugate vaccine, which is PCV13 as an infant, and then the polysaccharide vaccine a few years later if they develop asthma or a condition that increases their risk for invasive pneumococcal infection, including even kids with cochlear implants because of the effect and prevention of otitis media. Both of these vaccinations prevent infections due to Streptococcus pneumoniae, such as otitis media, sinusitis, pneumonia, bacteremia, and meningitis. And we sometimes informally call this the pneumonia vaccine, but it really only prevents pneumonia from Strep pneumoniae, and only the specific serotypes of Strep pneumo that are included in the vaccine. The meningococcal vaccine is usually given to adolescents, 11 or 12 years old, with a booster at 16. But it can be given to younger kids as young as 2 months if they're at increased risk for meningococcal infections, such as kids with sickle cell disease or asplenia. The meningococcal vaccine prevents Neisseria meningitidis infections, including meningococcal meningitis, pneumonia, and septic arthritis. All right. Next is the inactivated poliovirus vaccine, or IPV, which is given to infants to prevent polio. The polio vaccine used to be a live attenuated or weakened virus vaccine that was administered orally, and in rare instances this could actually cause polio, so it was replaced by the inactivated polio vaccine here in the US. The influenza vaccine is recommended both for children 6 months and older and also for adults. It's given once a year, and this prevents seasonal influenza. The predominant strains of the influenza virus that circulate and cause disease change every year, which is why people have to get a flu shot annually. The flu shot contains either an activated virus or recombinant viral proteins. And you may have heard about or even received a live attenuated virus vaccine given as a nasal spray, but this is no longer available. All right, the MMR vaccine prevents measles or rubeola, mumps, and rubella. And the varicella vaccine prevents varicella, which is chickenpox. The hepatitis A vaccine prevents acute hepatitis A, and the hepatitis B vaccine prevents acute hepatitis B, and therefore it also prevents chronic hepatitis B, which can cause cirrhosis and hepatocellular carcinoma. Then the last one is the HPV vaccine, or human papillomavirus. So there are several different versions available, but as of now, the one available in the US is a 9-valent vaccine given twice to preteens, both girls and boys, in doses 6 to 12 months apart. This vaccine targets the HPV types that cause genital warts and also cervical cancer, other genital cancers, and anal cancer. And while HPV can also cause oral cancer, and we know that the vaccine reduces oral HPV infection rate dramatically, in fact, although we don't have data yet on whether it prevents the oral cancers. Okay, so let me review. Before age 6, children should get Hep B, rotavirus, DTaP, Hib, PCV, that's the pneumococcal, IPV, that's polio, and MMR, that's measles, mumps, rubella, varicella, and Hep A. Then they also get the influenza vaccine seasonally. Then between 7 and 18, they continue with seasonal influenza vaccine and also get HPV and meningococcal vaccines, as well as a Tdap booster and any catch-up vaccines that were missed. Okay, so what about vaccinations for adults? We've mentioned most of these already, but it's important to know which routine vaccines are specifically recommended for adults. So we give the tetanus and diphtheria booster shots every 10 years throughout a person's life. And since there's been a resurgence of pertussis, it's recommended that the Tdap should be given once in place of the regular Td booster in adults. Then the pneumococcal polysaccharide vaccine, that's PPSV23, is given once at 65 years or older. It could also be given to younger individuals with high-risk chronic medical conditions, diabetes, liver, lung, or heart disease, residents of long-term care facilities, smokers, asplenic patients, HIV patients, and patients with CSF leaks. The pneumococcal conjugate, PCV13, also is recommended for everyone over the age of 65 if they have not already been vaccinated with PCV13. But we don't give both at the same time. They have to be at least 8 weeks apart if PCV13 is given first, or a year apart if PPSV23 is given first. And then influenza vaccine is continued to be recommended annually for adults. HPV is recommended for young women and men up to age 26 if they were not vaccinated as adolescents. And then again, you might also need to do catch-up vaccines with MMR and varicella if a person has never had the disease or the vaccines. And finally, the herpes zoster or shingles vaccine is indicated in all patients over the age of 60. So we assume that folks in this age group all had chickenpox as children, which means they're all at risk for shingles. And you can even give this vaccine to a person who has already had shingles. And then there are certain diseases that should be reported to government health authorities. This isn't very high yield, but some students have seen questions on reportable diseases. So the CDC publishes a list of reportable diseases annually, and then the states actually collect the data and submit it to the CDC voluntarily. So it's kind of good to have an idea about these because there won't be anyone to remind you in your clinic one day, oh, you're seeing a case of chlamydia, you should report that. So there are basically 5 different categories of reportable diseases, and you might be surprised by some of them. So there are sexually transmitted infections, including HIV, chlamydia, gonorrhea, and syphilis. Then there's viral hepatitis, specifically hepatitis A, B, and C. Then other vaccine-preventable infections like measles, mumps, rubella, diphtheria, and pertussis. There are diarrheal illnesses, specifically salmonella and shigella. And then finally, tuberculosis. All right, now it's time for the end of session quiz. First question, what's the current recommendation for the meningococcal vaccine? Without getting into too much detail, the main recommendation is all children should be vaccinated at 11 or 12 years old with the booster at age 16. In certain rare high-risk conditions, we sometimes give this vaccine to kids as young as 2 months old, but for most kids this is a preteen vaccine. Next, which adult patient population should receive the pneumococcal vaccine PPSV23? So this is all patients over 65, plus patients younger than 65 if they're members of certain high-risk groups, such as patients with chronic heart, lung, liver, or kidney disease, patients with diabetes, smokers, alcoholics, patients with CSF leaks, patients with asplenia, including sickle cell patients, and then immunocompromised patients, including those with HIV or congenital immunodeficiency state or leukemia or lymphoma. So again, don't memorize the list, but be familiar with the general idea. Everybody over 65 plus chronically ill people under 65. All right, next. Which diarrheal illnesses are reportable diseases? That's Salmonella and Shigella. And finally, which vaccines could prevent each of the following diseases? And some of these are pretty obvious. Seasonal influenza, that's the annual influenza vaccine. Hepatitis A vaccine. Hepatitis B, that's the hepatitis B vaccine. Hepatitis C, that's a trick question because there's no vaccine for hep C. Some types of anal cancer can be prevented by the HPV vaccine. Genital warts, also the HPV vaccine, since most genital warts are caused by HPV type 6 and 11, which are included in the 9-valent vaccine. Neisseria sepsis is prevented by the meningococcal vaccine. Epiglottitis, this one is the HIB vaccine. Whooping cough or whooping cough, this one is Tdap and DTaP vaccines, the pertussis-containing vaccines. Septic arthritis could be prevented by both H-flu and meningococcal vaccines. Clostridium tetani, that's TD, DT, Tdap, or DTaP, any one containing the T for tetanus. Clostridium botulinum, well, there's no vaccine for that one. Cervical cancer, that's HPV vaccine. Shingles, that's the zoster vaccine. Rubeola, this is another name for measles, so the MMR vaccine will prevent that. And then lockjaw is another name for tetanus, so you can prevent that with TD, DT, Tdap, or DTaP. All right, that's it for now. I'll see you next time.
This lecture is kind of on the long side, so we're going to keep the warm-up on the short side. The question says, what are the equations for sensitivity, specificity, positive predictive value, and negative predictive value? So sensitivity is the true positives over true positives plus false negatives. Specificity is the true negatives over true negatives plus false positives. Positive predictive value is true positives over true positives plus the false positives. And the negative predictive value is true negatives over false negatives plus the true negatives. Now make sure you know all those equations really, really well. Now let's go ahead and get started with the lecture.
In this video, we're going to discuss the healthcare system in the United States. This is something that is definitely important for you to know, both professionally and for your Step 1 or Level 1 exam. You will have a question about the healthcare system on your exam, maybe one question, maybe 5 questions. But it's something that you really do need to understand, and it gets largely ignored in other review courses and review books. So we've given you much of this information in your study guide. We have this quote in your study guide: medicine is a science, healthcare is a business, healing is an art. I heard this as a medical student, and I mention it here to remind you that our healthcare system represents a complex intersection of medical science, economics, corporate legal entities, and the psychosocial and spiritual aspects of healing. In some ways, each of these components stands on its own, but in other ways they are very much dependent on each other. So let's start with this first question in the study guide. What was the practice of medicine like before insurance? Well, physicians and hospitals could charge whatever they felt was fair to patients. Patients trusted physicians and hospitals to charge them a fair rate for their services. Patients sometimes incurred excessive, unforeseen medical expenses. Patients often were unable to financially compensate healthcare providers for the services rendered and instead might offer something like chickens or handmade crafts. Physicians would often write off debts that patients were unable to pay. So without insurance, there was a certain degree of imbalance in the healthcare system. One of the goals of medical insurance is to establish more foresight and fairness in the system when there's prepayment for anticipated future ill health. In this way, the system becomes more balanced over a long period of time rather than having a lot of short-term disharmony. So in order to move on, there are a few healthcare terms you need to know. Look at the next question. Health insurance has premiums. What's a premium? It's the amount the insured person has to pay the insurance company. Usually it's a monthly premium. Maybe it's a $200 a month premium. Maybe it's $500 a month. A copay is the amount the insured person pays at the time of a service. So not only do you have to pay a premium every month, you also have to pay a copay every time you go to the clinic or the ER or for an outpatient surgical procedure or for an inpatient stay or whatever the visit is. And a deductible is the amount an insured person must pay out of pocket before the health insurance begins to pay for the remaining healthcare expenses. So if you have a high premium plan where you're paying maybe $1,000 a month, your deductible is probably going to be very low, and it's not going to take much money to reach that deductible. But if you have a low premium plan, you're only paying, say, $100 a month or $50 a month, you're probably going to have a very high deductible where the first $5,000 of medical care is not covered by insurance and must be paid as an out-of-pocket expense. Next, let's talk about the third-party payer system or private pay health insurance. The financial duty of the patient is to pay the monthly premiums, copays, and deductibles we just discussed. The risk is paying more in insurance than what is received in medical care. And this is particularly common in young patients who pay into the system but don't need much health care. So from a certain perspective, it's a waste of money for a young patient to buy insurance. And we'll talk about why that's an issue in a minute. The reward is that, number one, that there's a financial benefit if the cost of medical care exceeds what is paid to the insurance company. And number two, there is peace of mind in knowing that you have insurance to pay for any catastrophes. And this peace of mind is really important because if you're worried about what would happen if you got ill, then you're not going to be as productive as you could be. Now, from the perspective of the insurance companies, they have a financial duty to pay the healthcare expenses beyond whatever the patient is required to pay. The risk they are assuming is that they have to pay out more than what they are collecting from the patient. And they try to spread that risk over their entire subscriber population so that there's less risk and more fairness. The reward or profit comes if the patient pays more into the insurance than the company has to pay out for healthcare expenses. The next question says, what problems came about when health insurance was introduced? In short, everyone tries to get the biggest slice of the financial pie that's in the hands of the health insurance companies. Before, you just had physicians and patients. Now you have third-party payers, and everyone's trying to get the most out of the system. Health insurance companies leverage their volume of subscribers to drive down their reimbursement to medical care providers. Providers still provide care because they agreed to do so. Healthcare providers and hospitals counter by increasing the cost of medical care. Insurers pay because they agree to pay. They agreed to do so. Patients demand more and more care in order to get what they have already paid for. They'll start going to the clinic more frequently. They'll start having unnecessary procedures. Insurance companies end up receiving too little funds from patients to pay the rising costs of health care. So again, patients are trying to get the most out of the system, insurance companies are trying to get the most out of the system, and physicians are trying to get the most out of the system. So the healthcare system is constantly being refined to maximize fairness. So we need to introduce a few more terms. A network is a group of healthcare providers that has agreed to take reduced payments in order to have access to a larger number of patients that are subscribing to an insurance plan. And major medical is a high deductible plan that covers the patient in the event of excessive medical expenses. So in theory, by placing limitations on the loopholes people found to tip the scales in their favor, the entire system is made more fair. But in reality, more rules results in higher administrative costs, and there are always more loopholes to be found. So as a result, you get things like health maintenance organizations, or HMOs. This is where the PCP is a gatekeeper to more specialized care. If a patient wants to see a specialist, he has to go to the PCP first. Obviously, patients don't like having to go to the PCP in order to see their specialist. Insurance companies do like patients going to their primary care provider first because a lot of times the PCP can provide care at a much lower cost than the specialist. And with an HMO, in order for medical expenses to be covered by insurance, the provider has to be in the HMO network. You have a network of physicians that have agreed to the HMO plan, again, in order to gain access to more patients. And as a patient, either you use the in-network physician or you're going to pay a lot more money to go outside of the network. Then a preferred provider organization, or PPO, is where there's no gatekeeper to see the specialist. As a result, individuals don't have to go to their PCP. They can choose whatever specialist they want. So the patients are happier with this. However, the cost is still higher for out-of-network care. And this plan tended to cost more than the HMO plan because of the higher specialist costs relative to the PCP being able to provide the care. The next question says, what problems came about when HMOs and PPOs were introduced? The HMO and PPO drive down the payments to physicians and hospitals. The physicians receive less compensation, and the quality of visits is decreased in order to generate a higher quantity of visits. The patient pays more and more for less and less medical care. In short, the third-party payers drove down the cost of care, but the physicians counter by decreasing the quality of care. In this scenario, the patient loses on quality. Physicians that are unsatisfied with the new arrangement leave the system and establish new systems. Maybe they go back to the old system and stop accepting insurance. There's some freedom to go in and out of the system, but that's becoming more difficult as time goes on. So if the physician wants to establish a new system, what options are there? Minor emergency clinics are heavily utilized by patients without third-party coverage, but they usually offer no primary or secondary prevention. There's also cash-only clinics. This is where physicians exit the insurance system and say, you know what, I'm tired of dealing with insurance companies, I'm just going to accept cash only. The physician refuses to take any third-party payment, essentially returning back to the old patient-physician system. The patient may or may not carry major medical coverage. A sliding scale clinic is another option. This tends to be more of the non-profit clinics. So the patient pays a nominal fee based on their income, their ability to pay. These clinics are usually run by charities with a volunteer physician in order to minimize costs. And to add another level of complexity, some physicians will develop what are essentially their own insurance plans for their patients. This is called concierge medicine. This is where the physician charges an annual fee, maybe $1,200 a year, for a specifically designated set of services, possibly unlimited visits, maybe 4 visits a year, whatever bundle of services a physician decides to provide for that fee. Boutique medicine is where the physician offers unique services that aren't covered by insurance but are desired by affluent patients, usually cosmetic in nature, in order to increase clinic revenue. Botulinum toxin injections for wrinkles would be an example of a boutique service. Insurance companies aren't going to pay to correct wrinkles with Botox, but boutique medicine services can generate a little additional revenue for the physician. In group physician networks, or when physicians say, you know what, we're tired of third parties taking a piece of the pie, let's just get together with a group of physicians. So in an effort to regain control of their own payments, physician groups can form clinics, build their own hospitals, and run their own surgery centers. And what they usually discover is that in order to run such a big venture, you need to create a hierarchical structure with its own administrative costs. And so in some ways, they just recreate the business they just left. But as physicians become more business savvy in this process, business professionals and physicians start communicating better. They start to develop some pretty inventive solutions, like the list you see in the study guide. A formulary is a list of medications for which insurance companies will pay. Generics are preferred, but there's also a list of medications that the insurance company will not pay for, but the patient can choose to pay for them on their own if they like. Utilization management is when you have someone whose job is to evaluate the appropriateness, necessity, and efficiency of healthcare services. So if a patient only needs to stay in the hospital for 3 days, but some physicians might be keeping them for 4 days, that's not the best utilization of the healthcare system. So those utilization management professionals try to hold individual physicians accountable for thinking about how much things cost. The resource-based relative value scale is a scale that determines what a physician should be paid for a given procedure or service as determined by the CPT code. This is where the third-party payer says, okay, if a primary care physician in Texas does an EKG and reads it, we'll pay one fee, but if a cardiologist in New York does an EKG and reads it, we'll pay him a different fee, because there's differences in specialization, differences in location, and differences in liability costs for each of those physicians. So there are individuals that determine how much should be paid for each service, for each type of physician, for each region of the country. Again, the goal is to make the system as fair as possible. Evaluation and management codes, or E&M codes, are numeric codes that communicate a level of care provided to the patient so that the physician can be fairly and adequately compensated. For example, a simple outpatient clinic visit, a physician might document the visit as a 99212 code. For a complex outpatient clinic visit, the physician might document the visit as a 99214 code. ICD-10 are diagnosis codes that help clarify compensation. CPT stands for current procedural terminology. These also are numeric codes that communicate what specific procedure a physician performed. For example, if you performed a lumbar puncture on a patient, you would document it as a 62270 in order to receive reimbursement for that particular procedure. So now there are more complex, bigger entities like managed care organizations, or MCOs, or healthcare organizations. You can also group accountable care organizations in here. These are organizations that attempt to maximize the quality of care and minimize the cost of care. They use techniques such as encouraging patients and physicians to choose less costly care, providing recommendations regarding inpatient admissions and lengths of stay, and emphasizing preventive medicine. These things are all accomplished through a designated utilization management person or department. In the EHR, or electronic health record system, is important to those entities because in theory there are great efficiencies to be gained. Specifically in the ease of sharing records with other physicians so that redundant tests are not performed, in improving primary and secondary prevention through the use of system reminders to the physicians, and reduction of medical errors in prescribing medications. Now, the reality of the electronic health record system is that most physicians do not like to use it, and it's starting to look like it does not improve the quality of healthcare delivered. My suspicion is that this is because when using the EHR, more of the art of healing and therapeutic bedside manner is lost. So since it is a loss for the art of healing, it may also be a loss for the business of healthcare. Additionally, physicians complain that they see fewer patients in a day due to the burden of the EHR. The reality is that some healthcare systems will prefer to use the EHR and some will prefer not to use an EHR. The next question says, what about those without the financial resources for healthcare? Let's talk about Medicare and Medicaid for a second. Medicare and Medicaid is essential government health insurance for specific groups of patients. So a patient over age 65 qualifies for Medicare. Patients who are disabled or destitute qualify for Medicaid. So maybe you can remember the E at the end of Medicare stands for the elderly, and the D at the end of Medicaid stands for disabled or destitute. There's the Children's Health Insurance Plan, or CHIP. CHIP is a combination of state and federal funding of children's health care. With CHIP, the state and federal government assists parents in paying for a child's medical care when the parent is having financial difficulty paying for medical care on their own. City, county, and state-funded health networks are more local networks that we develop to care for indigent patients that are paid for by local taxes. Federally funded teaching hospitals receive federal funds to help cover the cost of teaching medical students. Federally funded VA hospitals are a network of hospitals just for military veterans. And then there's the Affordable Care Act. This is relatively new and seems to be changing every year. It's unlikely to be on your test. Now let's go in a slightly different direction and talk about how physicians are compensated in all of these systems. This is highly testable. There's fee for service, where payment is provided for a specific service. You're going to get paid a certain amount for a runny nose visit and a higher amount for seeing a patient with multiple chronic complicated problems such as coronary artery disease, COPD, diabetes, hypertension. One involves much more complex decision making, so you're going to get paid more for that particular visit. Capitation is where the physician receives a fixed payment for a specified period of time or a specified number of patients. This could be ER shifts or minor emergency shifts, or a concierge practice where they're paid by the year. With ER shifts, typically physicians are paid by the hour. HMOs may also have a capitation and pay you to provide care for a certain number of patients in a pool, regardless of how many you actually see. Salary is where the physician is paid a specific amount regardless of the amount of work performed. This is common in university hospitals. If a physician at a university hospital is taking care of patients and teaching, how do you compensate for teaching? How do you determine what is a fair reimbursement for the teaching time? Most physician educators are given a base salary, and that covers their fair compensation. Pay for performance is where the physician earns more if he or she meets pre-established targets. So the healthcare organization pays you more if you're meeting certain criteria, like vaccinating a certain percentage of the patients, or making sure they get their colonoscopies, or checking hemoglobin A1C in all of the diabetics. Non-payment for performance is where they don't pay you if your patient has a complication that could have been avoided. So not only is there an incentive to do well, now there's a disincentive to do poorly. Pressure sores acquired during a patient stay would be an example of an avoidable complication. So where are we now? What problems is the healthcare system facing currently? Well, there are young invincibles. Young invincibles are people, usually under the age of 30, that tend not to have many health problems and tend not to purchase insurance. So in order for a third-party payer to afford to care for an ailing patient at a low premium, healthy patients must be present to bear the burden of the additional expense. If you are an insurance company with an insurance plan only covering patients over age 80, do you think the costs that you'd have to pay out would be excessive? Absolutely. You'd have to charge those patients a lot of money. And so a way to get around that is to say, you know what, I'm going to take care of patients 80 and older, and I'll take care of patients 15 to 25. Those younger patients aren't going to cost so much, so they're going to share the burden of the 80-year-olds plus expenses. One of the selling points of the Affordable Care Act is that everyone shares the burden. Freedom of choice. Patients that need others to carry the burden of their healthcare expenses are at odds with those that want to be free not to have to carry that burden. So the 80-year-olds are saying, come on, young guys, help us out here. And the young patients are saying, I don't want to pay for health insurance. I don't even need insurance. So there has to be a meeting in the middle somewhere, and that is what makes the health insurance system so complex. And the next one is excessive complexity. This overly complex system leaves patients at a loss to understand where they need to go for health care. Plus, you have to hire people just to manage the complex system, and those additional staff drive the cost of health care even higher. And of course, more administrators means higher health care costs. Everyone still wants the biggest possible piece of the pie. Patients want the best, most expensive care. Physicians want the highest reimbursements. Insurance providers and drug companies want the largest profits. The next one is physician shortage. Many physicians now see better opportunities in other fields and are leaving full-time medicine. The population continues to increase, and the percentage of geriatric patients increases, and there simply aren't enough physicians to go around. And another problem is the concern of insufficient government funds. Specifically, it will be very difficult for the government to pay for Medicare for the baby boom generation. So what are some of the solutions that are developing? I'm not saying that these solutions are the correct solutions. These are just some of the things that we see taking place. Additional government involvement in the healthcare system so that citizens have access to some level of affordable insurance. Patients taking responsibility for their own health via the internet, via complementary and alternative medicine, via over-the-counter medicines. We're definitely already seeing this. This has created a booming industry in the sale of vitamins and herbs and alternative medicine therapies. Patients seeking U.S.-trained physicians practicing in developing countries where the cost of care is low. So maybe you go to the Philippines to have your hip replacement surgery because it costs much less there. This is called vacation medicine. New generic medications that help lower the cost of care. As many brand name medications become generic, physicians are able to treat patients at a much lower cost. Cooperative healthcare teams that help reduce the need for costly hospitalization. So maybe you need to see a certain patient every single month because of their medical complexity. Well, if a PA can see the particular patient on odd months, and then you can see that patient every other month, you've just decreased the cost of providing care to that patient. or maybe a home health person can stop by on a daily basis and then report back to you on how things are going. Having these lower paid professionals help out the system can reduce the overall costs of care and help provide higher quality care. So physicians are now being taught how to run these particular healthcare teams. More mid-level practitioners to meet the rising demand. It takes a long time to train a physician. If you need more healthcare providers in a short period of time, go for the mid-level practitioner like a nurse practitioner or a PA. It only takes 2 or 3 years to train them versus 5 to 7 years to train a physician. Increased reliance on protocols established by evidence-based medicine rather than physician individualization of care. Reducing the privacy of medical records among medical professionals and insurance companies for increased efficiency in the coordination of care. Electronic health records, or EHR, also known as electronic medical records, or EMRs. I already discussed those earlier in the lecture. Quality measures that are followed, such as LDL levels, hemoglobin A1C, and screening colonoscopies, that may be a determining factor in physician compensation. All right, go ahead and go through the end-of-session quiz, and then we'll go through those questions together. First question, what is the difference between a premium, a copay, and deductible? A premium is the amount paid to an insurance company, usually as a monthly fee. A copay is a fee that the patient pays out of pocket at the time of service. A deductible is the out-of-pocket expense that needs to be paid before insurance begins to pay their portion. Which plan usually offers patients a greater variety of physicians to choose from? HMO plan or a PPO plan? The PPO plan offers a greater variety of physicians to choose from. Next, what is the difference between being paid by capitation and fee-for-service? Both are ways that physicians are compensated. Fee-for-service is a payment provided for a specific service like a clinical visit or a surgical procedure, and capitation is a fixed payment for a set period of time or for a set number of patients, such as a shift at an ER or an emergency clinic, or a global fee in joining a concierge practice. Next, what must a hospital submit to a third-party payer in order to receive payment for services? You have to submit ICD-10 diagnosis codes and also CPT codes for what was performed on the patient. Next question, what department in a hospital oversees the maximization of the quality of care while minimizing the cost of care? This is the Utilization Management Department, or sometimes it's called Utilization Review. That's it for the end-of-session quiz, and that's it for our healthcare system video. See you next time.
It's time for another warm-up. Let's get going. First question here, what is the classic presentation of a patient with giant cell arteritis? Well, the classic presentation includes unilateral headache, jaw claudication, and towards the later stages of the disease, you can have blindness or impaired vision. Next, in a patient with an elevated alkaline phosphatase, elevations in which other serum lab markers would point towards a diagnosis of liver disease. So think about AST, ALT, and GGT. All right, guys, that brings us to the end of the warm-up. Let's get to that lecture now.
Doctor, kiss me, you fool. But Barbie, I'm your doctor. If only my code of professional ethics didn't forbid it. Oh, doctor. Professional ethics be damned. In this video, we're going to talk about ethics, which on the whole is a 5-star topic. You're definitely going to have some questions on ethics, primarily in the form of clinical scenarios where you have to choose the most appropriate ethical course of action. But in order to answer questions on the ethical scenarios, we need to lay down some general ground rules. So let's start with 4 basic ethical principles that I want you to know. The first basic ethical principle is beneficence. Beneficence means doing good. So we as physicians have an ethical duty to act in the patient's best interest. The second ethical principle is autonomy, which basically means self-rule, the right to choose for yourself. So this includes both patient autonomy and physician autonomy. Patient autonomy means that patients have the right to choose for themselves what's done to their bodies. They have the right to know their options and to choose how they're treated, or to choose whether or not they're going to be treated at all. Then physician autonomy means that physicians have the right to choose what treatments they will or will not provide. But that has to be balanced with other ethical principles. So say there's some treatment that the physician considers unethical. If you consider abortions unethical, you have the right to choose not to provide abortions to your patients.
If you consider it unethical or immoral to prescribe birth control, you as a physician have the right to refuse to do so. But that's not the last word on the subject, because we have to balance the physician's autonomy with the patient's autonomy. So in these scenarios, the best thing to do is to refer the patient to a provider who might be willing to provide the care that the patient desires, provided that what the patient desires is medically reasonable and within the standard of care. The third basic ethical principle is non-maleficence. This means that physicians must avoid intentionally harming the patient. First, do no harm, right? And then the fourth ethical principle is justice, which means that physicians must strive to treat people fairly. This means we can't give preferential treatment to one patient over another just because you don't agree with the choices the patient's made in life. Now, it sounds pretty obvious, but unfortunately there are a lot of healthcare providers who are guilty of providing substandard care to patients that are obnoxious or insulting or who exhibit antisocial behavior or criminal behavior. And that's just inherently unjust and unethical. Another foundation of our healthcare system is the right to privacy. Patients have the right for their medical information to be kept private and confidential. And our legal standards for protecting patient privacy are established by a law called the Health Insurance Portability and Accountability Act, or HIPAA. Now, among other things, HIPAA sets the standards for storing and sharing certain types of healthcare information. But there are some circumstances in which confidentiality and the right to privacy are superseded by other needs, like the need to protect some third party. For example, child abuse would be a situation where a patient's privacy is superseded by the need to protect a victim or a potential victim. Child abuse, or even suspected child abuse, is a valid reason to ignore confidentiality and privacy in order to notify the state. Disease reporting is another example. States require physicians to report certain communicable diseases to the state health department in order to monitor certain diseases and protect the population at large. So if a patient has tuberculosis, that diagnosis is confidential, it's protected health information, but you're allowed to break confidentiality and share that information with the state health department because tuberculosis is a reportable disease. Schools are also exempt, meaning the school can require a student to provide a record of illness and vaccination status. And that can be shared with other schools that the student may be transferring to. You don't have to get that patient's permission to do that. Employers are also exempt to some extent, meaning an employer can ask that an employee provide a record of illness. They can also discuss with the employee any condition that would affect the employee's ability to work, but employers cannot discriminate based on health matters that do not impact an employee's ability to work. Now, here's a confidentiality scenario that could turn up as a test question. What if your patient's family member asks you to give them information about the patient? Say I ask my wife's doctor what he's treating her for. That's not unreasonable, is it? But my wife has the right to confidentiality and privacy. So the correct response would be to ask the patient's permission before disclosing anything to a family member. You need to ask the patient if it's okay to communicate that information to the family. And be aware that patients can grant permission to share that information with anyone they want, and they can rescind that permission at any time. So if you're having a family meeting and the patient says, well, you can discuss anything about my case with any of my kids, the patient still has the right to change her mind later on and say, don't tell my kids anything, only tell my husband. Again, the patient retains a lot of the power and authority. Another legal boundary placed around our core ethical principles is informed consent. Informed consent means that before you perform any procedure or administer any treatment, the patient has to give consent. That's patient autonomy, right? But on top of that, this has to be informed consent, which means that the patient has to have some understanding of the procedure or the treatment, and understanding of the risks involved and the expected benefits, and also the alternatives to the procedure. And this means that you, the physician, needs to sit down and have a conversation about the treatment. And we usually document this conversation and have the patient sign a form saying we actually discussed all these things and they understand and give their consent. Now, not all patients are capable of giving informed consent. Maybe you have a patient that's demented or delirious or even comatose. Well, how do we determine whether or not the patient has decision-making capacity? Well, for starters, a patient with the capacity to give informed consent has to be able to make a treatment decision and communicate that decision to the healthcare team. So a patient in a vegetative state who can't communicate a choice obviously lacks capacity. The patient also has to be informed. You've discussed the risks and benefits and alternatives, and ideally the patient should be able to repeat some of those things back to you to indicate that they truly understand them. The decision that the patient makes has to be consistent with the patient's values and goals. The decision has to be stable over time. Patients have the right to change their mind, but if they're constantly going back and forth on whether or not to have surgery, there might be a problem. And then finally, the decision is not based on delusions or hallucinations.
Then, if you determine that your patient lacks the mental capacity to give informed consent, the decision-making responsibilities fall to some surrogate decision maker. This is called substituted judgment, where you substitute someone else's consent in place of the patient's consent. But the idea is that the surrogate decision maker should decide whether or not to give consent based on what the patient would want, as if the patient were making the decision for himself or herself. Well, that sounds great, except how on earth do you know what the patient would have wanted? Well, this is what advance directives are for. Advance directives are instructions that a patient gives in advance about what kinds of things they would or would not consent to. So there's an oral advance directive where the patient has told people orally what he or she would want. There's also a written advance directive, which is also known as a living will. Now, these aren't necessarily binding the way someone's last will and testament is. Ultimately, it's up to the surrogate decision maker to follow the patient's wishes as outlined in the advance directive. And then, how do we determine who that surrogate decision maker is going to be? Well, one way is by legally assigning someone durable power of attorney for health care to make those decisions. That's completely separate from the advance directive. And in most states, if the patient hasn't assigned power of attorney, there's a legally established succession of surrogates, usually beginning with the patient's spouse. If there's no spouse, then it's the adult children. If there's no spouse and no children, then it's the patient's parents. If there's no parents, then it's siblings, and so on. Now, what about getting informed consent for minors?
In general, treating a minor requires that you get informed consent from the minor's parents or legal guardians. But there are some exceptions to this general rule, scenarios where you don't need parental consent in order to treat a minor. So you still need the patient's consent, the minor's consent, because of patient autonomy, but there are scenarios where the minor would be able to give consent for himself or herself. One of these scenarios is a patient that's at least 16 years of age, that's living on his or her own and managing his or her own finances. And in most states, those individuals are considered emancipated minors. Treatment of any STDs would be another such scenario. If you have a minor coming in with an STD, you can treat that patient even though the patient's parents may not be there. Minors can generally be treated for pregnancy without their parents' consent. Now, abortion is a little trickier. In some states, you do need parental consent to terminate a pregnancy in a minor. In other states, you only need to obtain consent from the minor patient herself. Treatment for drug addiction or dependency is another situation. A treatment for the child of a minor. So if you have a 17-year-old patient who's a mom, that 17-year-old minor parent can give consent for her children, even though she herself is still a minor. Another scenario would be a minor serving a sentence of confinement. So if you have a patient in juvenile detention under the supervision of the government, that's a scenario where the parents don't necessarily have to give consent. And then obviously, in emergency situations where parental consent is not available, you're able to go ahead and treat the minor. Let's talk about the kinds of specific ethical situations that you might see on your exam. First Aid has an entire page of ethical situations that you can read, and I suggest you read through those on your own. The tricky thing about ethics questions is that you can usually eliminate 2 or 3 of the answer choices as being incorrect pretty easily, but then you're left with at least 2 that seem equally right, and it's kind of hard to tease out why one's going to be better than another. I would generally recommend that you eliminate the choices that you can, and then rather than using up a lot of your time agonizing over whatever's left, just pick one that seems the most reasonable, flag that question for later review, and then just move on. If you have time at the end of the block, you can come back and wring your hands all you want, but don't let these ethics questions eat up too much of the clock. So before we talk through some specific ethical situations, let me give you 2 good rules of thumb. First of all, always be professional and maintain a good physician-patient relationship. Never be insulting or use harsh language. Those rude, uncaring choices are probably the ones you can eliminate right away. And then second, respect the patient's rights, including the right to privacy and the right of autonomy. Remember, the patient can always refuse any aspect of care that they don't want.
Now, with those rules in mind, let's talk through a few scenarios. You can take some notes if you want. First, let's talk pregnancy. This is a good, juicy topic for ethics questions. Say your patient is a pregnant teenager and her parents want you to force her to get an abortion. Well, the children of minors are governed by the minor parent. So this patient has the right to determine what's going to happen with their child. Same holds true if your teenage patient wants to keep the baby, but her parents want her to put the baby up for adoption. It's not the parent's decision, even though the child is still a minor. Now, if it's the teenager who wants an abortion, that's harder to answer because each state sets its own rules and restrictions about when a pregnant teen's parents have to be notified and when they have to give consent. But in general, prenatal care does not require parental consent or parental notification, but most states do require either parental notification or parental consent in order for minors to have an abortion, unless there's some medical risk. So if a minor comes to the emergency room with a miscarriage or an ectopic pregnancy, in those scenarios, you could treat the patient even without her parents' consent. Another big topic for ethical questions is psychiatric care. Say you have a patient with a psychiatric diagnosis like depression or anxiety or bipolar disorder or whatever, and the patient's seeing a psychiatrist and taking some psych medications. And the patient's clearly improving with this regimen, but now the patient's insurance company says they won't pay for any more psychiatrist visits. So what's going to be your next step? Well, one possibility is to call the insurance company's medical director and explain the situation and try to get the patient approved. Very often when a physician calls to request approval of something and argues that the patient really needs it, the insurance company is going to approve it. Another possibility is for you to keep prescribing the medication that the psychiatrist started. And you should certainly document the situation in the patient's medical record. Document that the patient was improving with treatment, and document that the treatment was stopped or altered because the insurance company denied payment. Now, what about a patient that's suicidal? Say a patient comes to your clinic and says, I've been thinking about suicide. Obviously, that's a scenario where you need to assess the seriousness of the threat. Thinking about suicide is not the same as planning suicide. But if you assess it and the patient's serious, you would first ask the patient if they would like to be hospitalized voluntarily for treatment. If the patient refuses, then you have the option of getting a judge to issue a mental health warrant, and that's going to involuntarily hospitalize the patient for a short period of time. Another type of ethical situation you might be tested on has to do with the financial relationship between a physician and a third party other than the patient, such as a hospital or an outpatient surgery center, or maybe between a physician and a pharmaceutical company. Now, in general, it's unethical for physicians to receive any kind of kickback or gift for referring a patient to a specific facility for health care, whether it's a surgical center or an x-ray facility, or even a company that supplies medical devices like powered wheelchairs. And referrals to facilities that the physician has an ownership stake in is also unethical. So say you own a partial stake in a radiology facility. Now you have a patient with a suspected kidney stone who needs a CT scan. Well, you can't preferentially send that patient to your CT scanner. It's more ethical to give the patient a list of facilities in the area and say, here's a list of CT facilities to choose from, and you can choose whichever one you want. You let me know, and then we'll set it up. Because the physician's rather going to profit if the patient does go to their facility, so the patient can't be coerced into doing so. It has to be a completely voluntary act on the patient's part. USMLE and COMLEX now include questions on quality improvement principles and safety science. Now, one topic that has come up is called failure modes and effects analysis, or FMEA. This is something that was first dreamed up by engineers for military equipment at NASA, but now it's being applied to healthcare. So let's take a quick look at this in your study guide, just so you've heard of it. The basic idea behind failure modes and effects analysis is to proactively, systematically evaluate a process to identify how it might fail, and then to assess the impact of different types of failure in order to identify the parts of the process that need to change the most. So it's not just what can fail, but which failures are the most serious and the most likely, and which parts need to be fixed. So first, you're going to list all the steps in the process. Then you identify the various failure modes, basically asking what could go wrong. Then you're going to drill down and identify the potential causes for each of these failure modes, asking why would the failure happen. And then finally, you identify the effects of these failures. You ask what are the consequences of each failure. So, for example, say you were asked to evaluate the process of implementing contact precautions in patients with C. diff colitis. Well, you start by listing all the steps in that process. So first of all, the patient has to be tested for C. diff. Then the lab has to notify the doctors and nurses of the lab result. Somebody has to order contact precautions. Somebody has to put up the signs on the patient's door and put out the gowns and gloves. And then the people that enter the room have to actually wear the gowns and gloves and then dispose of them properly. Then you would list the failure modes, such as the patient never gets diagnosed, or the patient gets diagnosed but the contact precautions aren't ordered, or the staff doesn't follow proper contact precaution procedures. And then for each of these modes, you could have several different causes. For instance, for the failure mode of staff doesn't follow procedures, maybe the sign wasn't posted, so staff didn't know that they were supposed to wear gowns and gloves. Or maybe they looked for the gowns and gloves, but they couldn't find them, so they went into the patient's room anyway. Or maybe they weren't trained on how to wear the gowns and gloves, so they didn't put them on properly, or they didn't take them off properly and they contaminated themselves, or they didn't dispose of the gowns and gloves correctly. So for a single failure mode, there could be several failure causes. And then you try to determine what the effects or consequences of each failure would be, and which ones are most dangerous and which ones are most common.
So if a failure is really dangerous or really common, it should probably be fixed before something that is rare or relatively benign is fixed. So that's failure modes and effects analysis. Let's briefly talk about medical malpractice. There are 4 basic elements of a malpractice claim. First, the physician has to have a duty to provide medical care to the patient. You can't sue me for medical malpractice because I'm not your doctor. I have no duty to provide you with medical care as of this moment. Then you have to prove that the physician breached that duty and that the patient suffered harm or injury from that breach of duty. And then there has to be some kind of damage that was suffered as a result of the harm or injury, whether it was physical damage or emotional damage or maybe financial damage by loss of income or whatever. And in general, the biggest risk factor for being sued for malpractice is the lack of a good doctor-patient relationship. In general, patients don't sue doctors that they like, that they have a good relationship with, even if that doctor makes a mistake. All right, that's it for our ethics discussion. Now let's go ahead and do the end-of-session quiz. We've provided several more ethical situations for you to consider, and as we talk through them, it should help you kind of prepare for the kinds of things you're going to need to be thinking about when you come across these on your test. The first question says, a patient had made it clear to you on previous visits that if something should happen to him, he would not want surgery. The patient is now admitted to the hospital with a condition that requires surgery, but because of his condition, he's incapable of giving informed consent. His friend relays to you that the man has told him numerous times he does not want surgery. His wife shows up later and tells you to do everything you can to save her husband's life, including surgery. So what should you do? Well, this question is dealing with substituted judgment. What does the patient want? The patient does not want surgery, regardless of what the wife is telling you. So they've given you 2 sources saying the patient doesn't want surgery. So the correct answer here is do not perform surgery. Now, in the real world, you might try to convince the wife that the patient didn't want surgery. You might have to go to court and present evidence that the patient didn't want surgery, including the testimony from the friend, including your previous notes and your charts. And the court would be able to say, obviously it's the case that this patient did not want surgery. So substituted judgment means you're doing what the patient would want. It's just a matter of how you come by that knowledge. Next, how should you handle a situation where you smell alcohol on a physician's breath while that physician is practicing medicine? You notify the physician's superior. Is it your responsibility to confront this impaired physician? No. But you do have an ethical obligation to tell somebody. So you figure out who the physician's superior is and you tell them. If it's a medical student that's impaired, you tell the resident on the team. If it's a resident, you tell the attending on the team. If it's the attending, you tell the head of the department. Next, a 36-year-old woman has a first-degree relative who had breast cancer at age 40. You recommend a mammogram, but she refuses to have one because it's too painful. So what do? Well, first of all, you want to investigate whether there's something that you can do to make the exam less painful, more comfortable for the patient. And second, you're going to discuss the risks, the benefits, and the alternatives, including the risks of not having the procedure, and then document this discussion and the patient's choice. Patients can decide what they want to do with their own bodies. If she doesn't want to have the mammogram, you just need to make sure to document that you discussed it with her. That way, if she comes back with breast cancer 5 years later, she can't claim, well, my doctor never told me I would get a breast cancer if I didn't have a mammogram. It's in the chart that you had this conversation. Next, you find yourself attracted to your 24-year-old patient. How do you handle the situation? Well, stay professional. In general, it's unethical for you to date your patients. Now, there are lots of different opinions out there about when it might be acceptable to date former patients, but in general, it's a bad idea. So just stay professional. Do you have to terminate this professional relationship? Not as long as you can stay professional. Then you also definitely want to consider having a chaperone in case there's any allegation of flirting or inappropriate behavior down the road. So consider a chaperone. But again, you don't have to terminate the relationship as long as you can stay professional. And the last question, a 72-year-old man in the hospital with an MI refuses to take his aspirin on the grounds that it makes him feel funny. So what do? So just like the mammogram scenario earlier, you should discuss the risks, benefits, and alternatives and document that discussion. You're going to need to educate the patient about why you're recommending aspirin. If you don't take the aspirin, your likelihood of having another MI is greatly increased. You don't want that to happen. So discuss the risks, benefits, and alternatives. Also educate and encourage the patient to stick with your plan. Another possible correct answer would be to investigate the patient's symptoms. Maybe he has aspirin-sensitive asthma and he needs to be on clopidogrel instead of aspirin. But ultimately, the patient has the final say about what they do with their own body, even down to which particular pill they're going to take. But whatever you do, don't get frustrated and refuse to treat the patient. That's certainly not the answer they're looking for.
Just because they refuse one particular part of your plan doesn't mean that you should ditch the entire plan of care or fire the patient. Work with the patient. Determine what you can do for the patient. And that's it for now. I'll see you next time.